Okay. Jamie? Morning, Michaela.
Morning, Karin. How are you?
I'm good. I am
working through some technical difficulties, I see.
Yes, but we are in good shape now, I think. In honor of you, I have Uppsala University here. So
Oh, brilliant.
at least your current location. Okay, we are live. So welcome everyone to the Lifebulb and Orexo Innovation Challenge in finding solutions for substance use disorder. I'm really excited to be here together with our partner Orexo. And I'm going to start out by just explaining a little bit what Lifebulb is, and then of course letting Michaela talk about Orexo, and then we're going to get into the main program, which is the highlight of today. So my name is Karin Hienberger. I'm the CEO of Lifebulb. We are a patient empowerment platform that bridges patient communities with industry. We source insights and solutions directly from those who are living with chronic disease. We are currently operating across 11 different chronic diseases, including substance use disorders. And those insights and solutions are really sourced to bring better products to the marketplace, including those that we develop internally. We're excited to be saying that within a month or so, we will be launching our first digital platform in the area of transplant. So today, though, we're focused on substance use disorders and an innovation challenge, which is, I think, the 7th of the kind that we are running with different corporate partners. And today, we're very proud to be standing side by side with Orexo. And here I'd like to introduce our partner and Michaela Udlander.
Hi, everyone. My name is Michaela Udlander. Today, I'm representing Orexo. And I just want to start off by thanking everyone dialing in, everyone from my company dialing in, for all the contestants online who will be competing today. And obviously, a special thank you to the whole Lifebulb team for all your hard work, and to the jury for taking time out of your busy schedule. Especially big thank you for the guys joining from the West Coast. I know that we have a couple online. Kudos for waking up this early. Just very quick intro on Orexo. I'm pretty sure that most online know us fairly well, but in case someone has missed out, we are traditionally we are a RX company focusing on SUD and mainly opioid use disorder. As of just last year, we ventured into a new area of digital therapeutics, where we are addressing a large unmet need within depression, within alcohol management, and with, again, opioid use disorder. But we very much understand that addiction is not a one size fits all. It's not a one-time treatment. It's a chronic condition, and it's highly personal to the individual. So we are always looking for new ways to approach addiction in a multifaceted way. And really, I'm a firm believer that no one understands market gaps better than patients and their care partners. So we are super excited for this. We're really excited for the partnership with Lifebulb, and really look forward to seeing your guys' pitches today. I got some insights already, but I'm super excited for everyone online to see what this diverse group of companies are bringing to the table today. And just good luck to everyone, and thank you again for joining.
Thank you so much, Michaela. Let us go, and Michaela already thanked the jury. And we have an incredible jury here today, and I'd like to introduce them a little bit more formally. So these individuals represent really different facets of this disease area. And that's how we always set up our innovation challenges, where we invite jury members to be able to assess the pitches, the companies in different ways. So starting here with Kajsa Gottenbeck, being an investment manager with Schibsted Growth, a venture capital firm, used to looking at a number of different business plans and focusing on the business of the pitches and the solutions. Jeff Hoffman, Chief Development Officer and partner at Havas Health and You, being an entrepreneur himself and having had a number of different startups, but also very used to looking at new technologies in his role at Havas, being a global advertising and marketing firm. Aaron Laxton, Director of Business Development at the Assisted Recovery Centers of America, being himself a patient, but also being in charge of managing and leading patient efforts within his company. Philip Rutherford, Chief Operating Officer of Faces and Voices of Recovery, a very large patient advocacy organization here in America, and being someone also in recovery and knowing what it's like to be applying different solutions. Also having a corporate background from Microsoft, knowing technology very solidly. And then Geraldine Utter, being a treating physician or in this space or therapist in this space, being also the medical science liaison at Orexo, having an incredible area expertise with a scientific background, really adding strong value to the assessment of these different technologies. I also want to introduce our guest speaker, who is our motivational speaker today, who will be giving us her story in the middle, really, of today. Lisa Smith, who has a background in law, but also is going to share with us her very personal story with addiction and importantly, recovery. So thank you so much to the jury members. And we are going to, actually, the format of today is going to be 10 minutes of pitches by each of these incredible finalists who have made it here out of a very large group of applicants that it was incredibly difficult to narrow down to these individuals. And we, I think, can share this view with our friends at Orexo. You're all winners today. You're all here presenting to this jury and audience. Of course, we will be designating a winner at the end of the day, but I want you all to really, really feel good about yourselves. So 10 minutes for each finalist, followed by 5 minutes of Q&A. And we are going to be starting with Mehran Talebinejad, who is the co-founder and CEO of NeuroCore. So let's start with the first pitch.
Hello. My name is Mehran. My background is in electrical engineering and experimental neuroscience. And today I would like to share with you what we're doing at NeuroCore. NeuroCore is a medical technology company focused on designing, developing, and marketing products and services that improve the quality of life for patients who suffer from mental disorders. Our vision is to bring sustainable relief for patients to smile and thrive. NeuroCore's ultimate goal is to cause a paradigm shift in mental health care with the brain team, integrating the patient's primary care, psychiatrist, neurologist, and radiologist to collaborate and come up with the best treatment plan for an individual patient. The brain team, equipped with innovative technologies, can precisely target individual brain electrochemical circuits and objectively assess and effectively treat mental disorders. The brain team will utilize connectomic analytics, resting state functional MRI, in order to precisely target individualized brain circuits. They will utilize a novel form of magnetic brain stimulation in order to effectively treat mental disorders. And finally, use connectomic analytics and post-treatment MRI scan in order to quantify therapeutic assessments with actual physical measurements and objective assessments. Today, I am not going to talk about brain stimulation, and I would like to focus on objective brain assessment in the context of substance use disorder, specifically given an individual baseline resting state functional MRI scan. I would like to talk about how we can assess therapeutic outcomes with a post-treatment scan. Brain stimulation for treatment of depression and substance use disorder target the same brain circuit, a subregion of prefrontal cortex with the most functional connectivity to the area 25. We are developing a connectomic brain assessment system utilizing resting state functional MRI, with which we can target individualized brain circuits. Specifically, we look at area 25, the prefrontal cortex, the default mode network, and the emotion network. We have a focus on major depressive disorder, but we are collaborating with another group which has a focus on substance use disorder. And in collaboration, we are applying connectomic analytics developed for major depressive disorder as a measure for internal validation of behavioral tasks like delay discounting and subjective questioning for therapeutic assessment in the context of substance use disorder. Again, major depressive disorder and substance use disorder share the same brain target. NeuroCore marketing is focused on objective assessment, enabling individualized treatment planning and big data analytics to gain insight into a patient's mental disorder. This will further increase better response and remission outcomes and provide an entire information process that will inform both physicians and patients. This is specifically important for cultural adoption and removing the stigma of mental disorders, helping patients and physicians understand it as a brain network condition while observing quantified improvements and therapeutic physical changes in the brain day over day, week over week, moving treatment of mental disorders to modern medicine. We are a team of engineers, scientists, and clinicians, and we all share a passion to realize NeuroCore vision and to bring sustainable relief for patients to smile and thrive.
Thank you, Mehran. And now we are going to move into the Q&A portion. So, jury members, do you have any questions for Mehran?
Okay, I can go. So this is Casa speaking. Thank you for this pitch. I'd like to understand better the opportunities to scale this to additional markets. What is your view on the next market and so on, or the next coming markets?
Right. That's a great question. For now, we have a focus on treatment-resistant depression for our market entry. In parallel to that, we are using the same principles, the same target, and the same process for substance use disorder because they're sharing the same target. And so I would think a range of disorders which are concerned with the prefrontal cortex and area 25, for example, other than treatment-resistant depression, substance use disorder, we have neuropathic pain and obsessive-compulsive disorder. which have a body of evidence related to prefrontal cortex and area 25. There are other disorders that might be involved in other brain regions or other brain networks that we haven't really looked at. And again, to summarize, treatment-resistant depression, substance use disorder, neuropathic pain, and obsessive compulsive disorder.
Okay, I see.
So hi, this is Jeff. So how many MRIs would you be doing along the treatment pathway? And are those all reimbursable? And follow-up question, is there a possibility that what the MRI is seeing does not correlate to the patient response?
So we are doing a baseline scan pre-treatment, and then depending on the treatment, we have multiple follow-up scans for assessment. For example, in a 2-day treatment, we will have a baseline treatment, day 0, one scan for day 1, one scan for day 2, and then follow-up scan whenever that is, several weeks or several days after. The first scan has a CPT code because a radiologist, a neurologist, or a psychiatrist can right now prescribe the first scan in order to look at the brain and make sure there are no other issues before getting into the brain stimulation. However, for the subsequent scans or assessments, we need to develop new CPT codes because right now there is no process for that. Did I answer your question?
Yeah, and the second part of the question is there any clinical study on an absolute correlation between what's seen on the MRIs and the patient response?
So we have that study, that's an ongoing study that we have with 20 patients where we are looking to correlate delayed discounting and subjective questioning with this data. So that data is not available now and we're expecting it by Q2 2021.
Thank you.
I have a question, Miran, regarding residual effect. So have you, with the 20 patients that you're working with, have you been able to kind of see what the residual effect is after the stimulation is done? How long are the effects of the treatment lasting? And if you don't know that now, how long, based upon your research, do you anticipate the effects of the treatment lasting?
So normally with conventional transcranial magnetic stimulation, the effects last in the order of 2 to 4 weeks. However, it's also subject dependent based on the level of treatment resistance, the status of a patient. So it's very patient dependent. We had a patient with effects lasting only 2 weeks. And this was an older gentleman who had a history of treatment-resistant depression with failures of electroconvulsive therapy, ketamine, among others. We also had a 19-year-old who got into remission and the effects lasted for over 1 year up, based on my knowledge. I was following up with her up to 1 year. And then basically the effects lasted more because she made a lot of changes to her lifestyle, moved out of her parents' basement, got a part-time job, and so on. So it's very subject dependent. But if we go into the physiological effects, neurobiophysical effects only, usually a train of pulses have an effect that lasts in the order of 30 minutes to 45 minutes. And the idea is we have back-to-back trains in order to build on that effect, increase connectivity, and basically provide a window of self-control for the patients in the order of 2 weeks to let them make more changes and basically build on top of that. Did I answer your question?
Yes, thank you very much.
Okay. Thank you so much, Miran. Thank you. Let's move to our next finalist, which is Lucinda Koza with iAlly.
Hello, my name is Lucinda Koza. I'm the founder and CEO of iAlly. the family caregiver's companion. The reason why I started iAlly is because in late 2018, I realized that rather than just being drunk and addicted to pills, my father's behavior was actually showing symptoms of several strokes that he had suffered. So I finally took him to the hospital, and by then, since these symptoms weren't noticed quickly enough and he didn't receive treatment quickly enough, he had suffered pretty extensive brain damage. I was very young. I was completely alone. Even though I have siblings and family members, I was the only person who showed up to take responsibility for my father's care. And the lack of advocacy and the lack of resources was absolutely shocking to me. Considering how young I was, how alone I was, there wasn't a single person who asked me if I was okay and if I would be able to take on these responsibilities. So I felt completely isolated. I really struggled with mental health, PTSD, depression. I felt very isolated. And the more research I did, the more I realized that there were so many of us, particularly millennials, who are in this situation, and we just don't talk about it. It's just not talked about in our society at all. So we all feel isolated and we all are not connected. So I knew that if I could connect all of us together on one platform, that we could have each other's backs and be there for each other and provide resources for each other. Even if we didn't have these external systems of support, we could be there for each other. 23% of Americans say caregiving has made their health worse. And this is as recent as a study that came out in May of 2020. There are now 53 million Americans that are part of this invisible, unpaid family caregiver workforce. 25% are millennials. That has probably grown now due to the coronavirus. The boomer generation is turning 70 at a rate of 10,000 people per day. Millennials are going to be the ones taking care of the boomer generation. $41 trillion is the value of assets that are going to be transferred to the children of baby boomers by 2048. Over half of family caregivers report moderate to severe burden. So, iAlly's mission and the way that iAlly will address this issue is to empower the caregiver. How will iAlly empower the family caregiver? First, we provide peer support and mutual aid. Second, we arm them with digital tools. Third, we provide access to experts, legal, financial, mental health. The first, peer support and mutual aid. For number two, to arm them with digital tools, iAlly has partnered with Backpack Health, a Konica Minolta service. So the iAlly group for caregivers on Backpack Health, it arms users with a direct data portal to each of their doctors and medical facilities. So they automatically get their data for their loved one. The first part of this is mental health. So we have a partnership with a company called Therapy. Basically, users get direct access to therapists' schedules and can schedule their own appointments. This is all about increasing transparency for both the provider and the patient. So sessions can be virtual, they can be done via chat even, or walk and talk. So you can meet in a park outside. iAlly Premium members get 15% off their financial gym membership. It's a national personalized service. We also have a partnership with Antidote, which is a digitized, personalized matching service for clinical trials. So obviously the family caregiver would be doing this for their loved one. They could quite easily find any available clinical trial to participate in. So the pricing model, we have obviously a free part of the platform, which includes the community and peer support, and also the partnership with Backpack Health. These are free, accessible to all, and then when we get into the experts, access to experts and the matching services, that's where the premium membership comes in. I was lucky enough to be interviewed in Authority Magazine and Thrive Global as part of the Heroes of the COVID Crisis, how Lucinda Koza and iAlly helped provide support for family caregivers. Here's the product demo.
iAlly is a website and app created to be the family caregiver's companion. It was created by a young woman who became her father's full-time caregiver rather suddenly and recognized the lack of support and resources available to caregivers in our millennial generation. The iAlly app provides personalized access to mental health providers, financial coaching, and education, legal counsel, and a digitized matching service for clinical trials. It also has a cool feature, the iAlly Checkup, which ensures that you are taking advantage of all the benefits you may be eligible for, as well as a personal caregiving coach. What I really loved about iAlly when I first found out about it is that the app offers a way for those of us taking care of kids or parents with significant needs, a centralized space for all of our medical documents, medical histories, medications, important notes, which makes it easier to keep track of everything. I struggle with executive function, I've talked about that before, and my kids have multiple medical conditions to manage. I know a lot of you are in the same boat. The app is a huge help. Additionally, as the family caregiver, all of your own medical information, documents, and medications are in there too, and the app encourages you to be thinking about how to take care of yourself and make sure you're getting to your appointments too while you're supporting your family member. You have access to all of this coaching as well as medical and mental health resources right inside the app, so it's all easy to find when you need it. There's also mutual aid opportunities to help right inside the app. So if you need help picking up groceries or getting rides to the doctor, you can ask for help from a volunteer. Or you can volunteer yourself if you want to be available to help others in your community. You can customize your own plan so you can choose the resources you need or want. It's all personalized and it's free to join. Thank you so much to iAlly.
And this is the team. Everyone on this team has been a family caregiver themselves, which I think is pretty special. Thank you.
Thank you so much, Lucinda, and welcome back to the jury.
I have a question. How does the peer support and the volunteers, how does that work? I'm thinking about this being in kind of far-flung communities. How are people matched up with peers, or is it via chats on community boards, or how do people get connected and stay connected?
Sure. So the community is very central. It's basically the dashboard for every user. And there are sort of codes for when someone posts, so they can say, this is an ask for help. And then they post, and then someone can respond, this is an offer for help. And so I thought about being more hands-on, but then I realized that the users really need to feel an ownership of their community. And also, I can't micromanage everybody. It's really, like during the pandemic, obviously, there are ways of helping that are very tangible, like, there was food insecurity and maybe you need toilet paper or bleach. And then also there are more virtual ways of asking for support, like, does anyone know the law in this state? Or, someone help me, I don't know how to brush my father's teeth, anything really.
Yeah.
So I'm really letting the users take ownership of that process.
Thank you. And thank you for what you're doing.
Yeah, it's fantastic.
Thank you.
Yeah.
Thank you so much.
How many members?
So,
How many members?
sorry, Jeff.
Sorry.
You go.
I was just going to ask how many members you have signed up and at the various levels.
Sure. So we have about 1,500 members signed up. We just launched the new levels. So I don't really have the best data on that right now because it's something that's being tested. So yes, so hopefully we'll have, and I think, I believe that the services offered are worth the monthly membership fee, and that it'll be seen that way by the users.
Isa.
Lucinda, I have a question related to that, the monthly membership fees. I was just wondering about the user's willingness to pay out of pocket for a service like this. How, because you mentioned some price point, how will you validate, or how have you validated that that's the right price point? And what is your estimate in terms of how many paying premium subscribers you will have in, like, say, 3 years' time for this?
Sure. Well, I did research on other, models, especially mobile apps that have subscription services, like mental health mobile apps. Like, for example, like Talkspace, I think to have unlimited chat with a therapist, it's like $65 a week. So I've actually since added in another level that would be basically everything that's included in the premium level, but also with a coach. So it would be with a caregiver coach or with a mental health provider. And then that would be paid through iAlly. So that would be part of the subscription fee. And it's when it is presented to the user, it's made clear that it's such a better price point than if they tried to go out on their own and find a therapist, a caregiver coach. It's actually going to save them a ton of money. So I think when it's presented that way, I think it will be seen as very worthwhile. And also I'm doing a lot of persona work on, like, who the super user is. And I really think that in such a state of need, that fee is very doable, but it does need to be tested and validated over a year, over,
And do you have a rough estimate?
We got to just close up here. So Lucinda, if you can respond to Kaisa's question on the 3-year estimate, or
how many will you have paying?
I think in 3 years, I think we'll have at least 100,000.
Thank you. Thank you, Lucinda.
Thank you.
Okay, let's move to our next finalist, being Rohan Dixit with Leaf Therapeutics.
Hi, I'm Rohan. I'm the CEO at Leaf Therapeutics, where we have created a smart patch for mental health. So a little bit about my story. As a teenager, I actually suffered from anxiety and depression. And I found a book about mindfulness that totally changed my life. And so I became a neuroscientist, studying mindfulness and why it has such a profound effect on mental health. And that journey actually led me to starting Leap, and I'm excited to share a little bit more about it with you now. So I want to start with kind of a little bit of an insight. As I mentioned at Leap, we're really focused on mental health, but mental health and addiction or substance use disorder are actually very intimately connected. So, if you look at the largest mental health issue in the country, which is anxiety, there are almost 40 million Americans who have it, but there are 20 million Americans who have substance use disorders. And within that group, almost 50% of people that have a SUDS issue also have comorbid anxiety, have anxiety occurring at the same time that they do their substance issue. And beyond that, if you ask people and kind of look at the research out there around relapse, anxiety, again, another mental health issue, is the number one trigger for relapse for people that have come out of treatment for a substance use issue. So mental health and addiction are actually really intimately tied together. And I'm going to explain a little bit why that is the case at a physiological level just a little bit later. Before we jump into that, substance abuse and mental health more broadly, a lot of the problems that are kind of existing in the current treatment modalities for these two broad disorders are shared. And so you can look at kind of three main issues that both of these disorders sort of have. One is that clinicians don't have clear biomarkers. So, you look at any other type of physical health disorder, right? Diabetes, for example. You would never ask a clinician to make an inference about how to treat someone's diabetes without giving them what the blood A1C levels are, right? What some blood glucose levels are. You wouldn't ask them to guess about treatment for that patient. And that's kind of the state that we're in currently with the mainstream of mental health and substance use. So there are no biomarkers. That's a key problem. The second key problem is that patients aren't being treated. 2/3 of people with a mental health condition, and this is an even larger fraction with substance use disorders, are not getting any treatment at all. And a big piece of that is actually that there aren't enough clinicians to deal with the scale of the problem. And finally, these issues are expensive to treat. They cost hundreds of billions of dollars to our healthcare system in general, but for individual people, it's oftentimes very expensive as well to find affordable treatments for substance use disorder. And so at Leaf, we have kind of pioneered a different way of looking at the problem that we think allows us to create a new paradigm for how treatment for substance use disorders and mental health in general is actually carried out. So the kind of linchpin, the keystone of that this program is the Leaf Smart Patch, which is a kind of see it here, a single lead ECG device, very thin, flexible, goes underneath the clothing. No one knows you're really wearing it. And this device is designed to measure at clinical grade accuracy a biomarker called heart rate variability, or HRV. I'll explain a little bit more about HRV in just a second, but essentially it is the best index that we have of mental health as well as substance use disorder in terms of craving, relapse, etc. So we pair that biomarker with a digital therapeutic. That therapeutic has been studied for 20 years. It's called HRV biofeedback, HRVB. But essentially all that therapy does is really, in a very self-guided automated way, allow a patient to improve their HRV biomarker in real time. And I'll kind of show you how that works with the Leaf in just a moment. So we paired this breakthrough device, which has a digital biomarker and a digital intervention combined in the same device, with a telehealth network of more than 3,000 clinicians around the country. And we've made the entire system insurance reimbursable to start to address the issue of cost. And so what is HRV? Let's dig into that a little bit more and explain why it's so interesting in the context of substance use disorder. So you can kind of see the device here on the body. It is a biomarker in the heart that is literally measuring the millisecond timescale differences from one heartbeat to the next. It turns out that that actually has a ton of information about your autonomic nervous system, which is the kind of body nervous system that is involved in emotional self-regulation. So if you think about mental health, you think about substance abuse, what is one of the key things that people struggle with? It is self-regulation, right? So for example, if you have anxiety, you may be in a stressful situation. How do you self-regulate your emotional response to that stress? Similarly, in substance use disorder, right? You may be in an environment around certain people or around certain triggers that cause you to feel symptoms of craving and to use again. How do you self-regulate that in the moment? Self-regulation is really important for these disorders. Now, if you look at people who, for example, have PTSD and substance use disorder, you can look at HRV as a biomarker and actually say, with a high degree of accuracy, who is going to be craving and have the highest symptoms of craving, just by looking at whose biomarker is lowest. That's pretty amazing. And if you kind of look at, for example, alcohol use disorder, HRV, this biomarker, again, is an independent predictor of who might be having most severe symptoms of craving. And that is independent of even anxiety, how much alcohol you're using, how much of a substance you're using, your age, right? These key things that we think of as traditionally driving a lot of the outcomes around substance abuse. But really, it seems to be there's this physiological biomarker that is intimately tied in the process and is driving some of the process. And finally, I'll just mention a more recent study. So this looked at people with alcohol use, again, coming out of residential treatment. And they showed people a cue card that had an image associated with alcohol, for example, a glass of wine or a bottle of beer. And what they showed was that your HRV response to that cue card, right as you were coming out of treatment, could predict who would relapse 6 months down the line. So HRV can tell you who might be most at risk for substance abuse. It can tell you who is craving in the moment. And it can also predict who might be at risk for relapse in the future. So it's a really important biomarker. And we pair this biomarker with a lot of algorithms and AI that allow us to pinpoint, for example, not only who might be at risk, but within that individual person's life, when at specific points of the day are they most at risk for craving, by really understanding how that biomarker changes over the course of time. And so what we can do with that information is really amazing. We can intervene with them in the moment where they need it most. With the device has a vibration motor built into it, a haptic motor. And what that does is it communicates to this person in real time, totally invisibly, what the state of their body is in the moment. And what we train people to do over 8 weeks with the Leaf device is to learn to interpret that signal and breathe and use biofeedback, these mindfulness techniques, right, to upregulate their biomarker in real time and reduce their risk for relapse and craving. And this is really key. What it's doing is kind of this intervening in this behavioral health loop that a lot of us get into. There's a trigger, our mind, and then our body start to react, and it becomes this vicious cycle. What you can do with a device like the Leaf is intervene at the moment that the mind is starting to go into that negative cycle and give somebody intervention right then when they need it most. And perhaps you can even alert somebody like a clinician or a peer or a family member in the moment where they need help, rather than asking that person to reach out proactively, which is often really tough for people. So, this is a little bit about how we train people with our app. We have a mobile app that accompanies the device, some clinical trial data showing over thousands of doses with the device. We can reliably improve this biomarker HRV almost 10 points. We connect into a great network of clinicians all around the country so that we can plug in to existing primary care physicians, offices, for example, and all kinds of other clinical environments, and provide a support structure for teaching patients how to use the device and gain the most utility out of it. So we have great advisors at UCSF and Stanford. This is Nolan Williams, who's a great researcher at Stanford. And what we've done really is to work with some of the greatest minds out there in mental health, in biomarkers and physiological markers of mental health and substance use, and create a broad kind of technology that can apply to not only anxiety, which we just received FDA EUA approval to treat, or a Class 2 FDA medical device, but also treating and diagnosing disorders like depression, substance use, bipolar, PTSD, and on down the line, using the same fundamental technology. And what's so incredible about that is that I think for the first time it's giving us an opportunity to intervene with people across conditions that are often not treated to the degree that they should, with a technology that is scalable, that is effective, and that can reach people without having a lot of those traditional side effects that you get from a lot of the pharma treatments that are out there. And so I wanted to thank you so much for taking the time to learn a little bit more about what we're up to here at Leaf, and I look forward to answering your questions. Thank you.
Thank you, Rohan.
This is Aaron. I'll start. I have one question. I have a lot of questions, but I'm going to limit it to one. I think this is a very interesting concept. Do you anticipate a challenge? So this is, I see a twofold challenge with the buy-in from the patient side, which I think would be the easier one. But this only works if you have medical buy-in. And so you have hospitals and clinics and the medical community that utilizes all this great data that's collected. So how do you anticipate addressing that challenge?
Thanks, Aaron. That's a great question. And you're right. I think convincing the medical profession and in general to do anything new is really hard, which I think you know. Yeah, I mean, part of what we have done is try to make it as easy as possible to use. So that involves kind of like reducing the amount of time that a physician has to spend, understanding and interpreting data, making things simple, making things easy. But a key part of that also is having it covered by most insurance plans now. So that allows us to basically, let a physician get paid for offering it, and also for a patient, really critically, right? It's covered by your insurance, so on average ends up being about $10 a month, which helps a lot.
Thank you.
Yeah, absolutely.
Hey, Rohan. I absolutely love this concept. For me, the first thing that came into my mind, it's like, well, like we're really helping people get in front of a relapse, and that biofeedback technology really complements cognitive behavioral therapy, because that's what we do in a therapeutic dynamic is we teach individuals how to identify, triggers for relapse and really try to, pay attention to the people around you and how you're feeling, in your body and things of that nature. So I really like it. My question is, folks that have co-occurring conditions with substance use disorder in conjunction with what we would call severe mental illness, whether it's anxiety or major depressive disorder, they're often on a lot of psychotropic medications. And I'm just wondering how psychotropic medications could impact or could produce an inaccurate read with HRV, or if there's a way that the algorithm and the technology learns you, at baseline when you're on psychotropic medication, and kind of, learns how to read you, even though your HRV may be different. So if you could just speak to that a little bit, that would be great.
Absolutely. Thanks for the question. The Leaf basically personalizes to you, as somebody with anxiety, as someone with a substance use disorder, right? You want something that is actually understanding you and not geared towards some random generic person out there. And so that's kind of how we get around some of these issues, by basically looking at your baseline and seeing how does your HRV change throughout the day in different situations, and then building a profile for you. I think longer term, though, it's actually an open question. HRV changes with a lot of different kinds of medication. And so I think it's a matter of building a larger database and understanding. This biomarker is kind of just coming into the forefront. So how does it change with, for example, psychotropic medications? I think that's something that we're going to start to learn a lot more over time.
Thanks.
Rohan, tell me about scale for this device. What kind of scale over what period of time? So within 3 years, how many of these could be in the marketplace?
Yeah, so we're currently at about 3,000 users. In 3 years, we hope to be over 10,000 patients. And so I think a lot of what we've seen with COVID is the acceleration of need for tools like, that are being presented today. Frankly, everything that's being presented today is incredibly needed, and I think there's an increasing demand for it. We'll see what happens after the pandemic ends, but I have a feeling that a lot of the mental health issues are going to linger for a long period of time. And so I think there's a lot of room for growth for these tools.
Thank you, Rohan.
Thank you.
Okay. We have to move to the next presenter, the next finalist, being Bo Man with Sober Grid.
Welcome to Sober Grid. Sober Grid is the leading platform for individuals in or seeking recovery from substance use disorders in the world. There are 3 main challenges and unmet needs in the addiction healthcare space. Number 1, 90% of people that need to access care for substance use disorder do not access it. Sober Grid has solved for this. We have designed an easy-to-use platform that has engaged over 300,000 people to engage in their substance use disorder care. Our user experience and user interface is user-friendly, cost-effective, and our platform is free so that individuals can access care 24/7. Meeting people where they are is very important, and Sober Grid has done that through the use of peers with lived experience, which shows that individuals are more likely to open up to than clinical staff. Again, you can access Sober Grid 24/7, anytime, anywhere, and this has made the adoption of expanding the individuals who will engage in their substance use disorder care. The second problem is, for those that do access care, efficacy rates are less than 30%, which means we have to find treatments for the other 70%. The third problem is, due to isolation, we are seeing overdose rates that are at historical highs. This was seen by county governments examining the overdose rates and looking at the time period from quarantine and beyond. Sober Grid combats isolation with a global community accessible 24/7 at the touch of a button. Let me take a minute and tell you why I started Sober Grid. I'm a patient entrepreneur. That is the main reason I started Sober Grid. I was alone and isolated, and I wanted support from peers, and I wanted it 24/7 on demand. Now, over the years, as I've developed the business, I became even more acutely aware of existing therapeutic offerings working well for some people while not working well for others. Studies show that on average, a 30% efficacy across various treatment options that are currently available. While it's great to save that many lives, I want to serve the 70% who don't respond well by developing more therapeutic offerings with greater efficacy to the market. Last year, I lost a brother-in-law to opioid use disorder after he tried several treatment modalities and they didn't work for him. After his prescription for a high school athletic injury led to his death at the age of 30, I knew I had to do whatever I can to bring more treatments to market so everyone has a modality that can help save their lives. For that reason, we are building the Sober Grid platform, which can help deliver various new interventions using artificial intelligence to deliver the right intervention to those at the right time. Talking about interventions, we have developed artificial intelligence with our research partners from Harvard Medical School and the University of Pennsylvania Perelman School of Medicine. We have done this with funding from the National Institutes of Health. We first did a phase 1 feasibility to show whether or not we could accurately predict. We demonstrated a successful feasibility study, and we showed that we could accurately predict an impending relapse risk increase using our AI. We use deep learning algorithms and natural language processing to accomplish this. Now that we've successfully shown that we can predict, the National Institutes of Health has provided us with another $1 million in funding so that we can go on to phase 2 of our randomized clinical trial and show with more rigor our ability to accurately predict. Now, if you can predict, that's not enough. If you know that someone's about to relapse, then you need to be able, or at a higher risk of relapse, then you need to be able to do something about it. So that's when we acquired the telehealth peer recovery coaching company Ascent, founded out of Ohio. Ascent has state-certified addiction recovery coaches that are available 24/7. So now, if an individual is approaching a higher relapse risk, we're rolling it out where a coach will contact them, offer them the care and support that they need, and hopefully lower the relapse rates, the overdose rates, and improve the health outcomes. But that's not the only type of intervention that we're going to have. We are currently co-developing a virtual reality intervention that's also funded by the National Institutes of Health for close to $2 million. And that intervention is a virtual reality meditation modules. And we're making meditation modules specific for opioid use disorder, specific for alcohol use disorder, and specific for stimulant use disorder. We're doing this in a randomized comparison trial that's done over 2 years with the National Institute of Mental Health Innovation Center and the University of Colorado and our co-development partner TRIP, which is a digital therapeutic company based out of Los Angeles. So what other types of interventions will we develop? We will develop online health education programming, digitized CBT modules, other virtual reality modules, cognitive behavioral therapy modules, psychodynamic therapy modules, de-stress modules, as well as validate more clinically related artificial intelligence and predictive analytics. Our app has an outstanding 98% satisfaction rate from over 4,000 surveys. When surveyed by an independent third party for the top addiction therapeutic app, survey respondents indicated that Sober Grid was their most favorite app to use. Now, I told you about some of the research efforts that we're doing. I just wanted to highlight that we have a strong focus on clinical trials and research. We have a team of 7 people that are dedicated full-time to our research and development department. A lot with many with experience running clinical trials funded by the NIH, the CDC, and other forms of government, as well as the private and industry. So our first trial demonstrated feasibility when we did the AI, but we also have conducted a phase 1 trial that was funded by the National Science Foundation, and that total funding is shy of $2 million. And we were successful in a feasibility study. And what that is we're building a researcher software, which is a clinical trials management software that will allow pharmaceuticals or other entrepreneurs of digital therapeutics to recruit participants from our large and growing user base, enroll them into the studies, manage the studies, deliver the therapeutic, whether it's a digital therapeutic delivered in our app or outside of our app, to the end user that they've recruited, compensate those individuals, and manage the study and clinical trial from soup to nuts. We're doing this, and one of the things that it accomplishes is that we want to roll out the best-in-class digital therapeutics, and we realize while we can develop some great ones on our own, to bring the best-in-class into market, into our platform, is the best way for us to do that. And that software can also help with delivering studies, clinical trials for traditional pharmaceutical drugs as well as the digital pharmaceutical. We'll have a placebo app so that there can be a comparison trial to be used for that. So I told you that we started off with the coaching as the first intervention. One of the reasons we did that is because coaches in and of itself have therapeutic value. They're individuals with lived experience, but they also help an individual. They're agnostic to the different modalities that are used. So they help an individual develop a recovery plan. So an individual could say, well, taking my Suboxone is important, attending cognitive behavioral therapy or attending my psychologist appointments are important, or doing this digital therapeutic. And a coach will help them adhere to that plan through reminding them and coaching them and making sure that the adherence goes up. We did a study using our coaching program that was done by Case Western University, and it showed a 20% increase in completion of intensive outpatient programming at a treatment facility in Ohio. So we know that not only does it increase the psychosocial support, but it also helps increase different modalities of treatment. And that can be used both with our therapies and with therapies from other individuals. Our coaches are also certified in co-occurring mental health. They're certified in substance use disorder and mental health coaching. So there's a huge co-occurring percentage of individuals with both substance use and other mental health diagnoses. And so having that coaching available for that is huge. So right now, our market adoption has been fairly significant. We have seen over 300,000 patients from around the world. We are the largest substance use disorder digital therapeutic out there in terms of membership. This is a testament to how much our patients love our platform, and our app should be used close to 20 million times this year. Now, let me talk to you about our revenue model. First, we have coaching, which is already covered by insurance. Then we're going to have virtual reality. Now we're going to have other digital interventions. Then we'll have data that we can sell, as long as it's de-identified and anonymous, to payers and providers. And then we'll have our clinical trial software that we will have a fee from as a software as a service. We should be able to get, just the coaching alone, $30 million. In 2018 to 2019, we doubled our revenue from $800,000 from going from $400,000 to $800,000 in 19. And in 20, we should do well over $1 million. Like I said, we should be somewhere north of well north of $30 million in coaching revenue 4 or 5 years out from now. So thank you so much. I believe that we filled an unmet need. We've demonstrated adoption from the NIH, from several clients that we have. We've grown our clients both from Ohio. Now we have clients nationally, from our revenue, from the user growth, and from the feasibility studies. Our goals for the upcoming years are 2 clinical trials and to develop our predictive analytics using additional factors such as stress. Our partnerships have included Harvard Medical School, University of Pennsylvania Perelman School of Medicine, the NIH, and many of our clients across the country that are county mental health and substance abuse boards, as well as private companies. Thank you so much, and we look forward to the competition.
Thank you, Bo. Questions from the jury?
So this is Aaron. I have one question centered around scaling it up. So as a licensed social worker, I can't provide services in another state unless I carry a license in that state. And so for reimbursement purposes, do you anticipate a challenge with your coaching? It looks like most of your coaches are centered out of Ohio, but as you scale up to all 50 states, how do you anticipate addressing this licensure issue and reimbursement issue?
So we are scaling it up with coaches, and coaches will be in each state. So we have hired primarily in Ohio because that's where we began, but now we're currently hiring in California in different areas, so that we'll have coaches certified in each of the states.
Yeah, I also have a question. You mentioned you were going to raise $3 million now, right? How far will that take you, and what will you use what will you use the money for?
Oh, sorry. So I was saying we have raised $3 million in private investment. And then, so we were profitable several of the last quarters. So I think, we can raise money, but we're not in a position where we have to raise money. So if we raise money, it would be to grow, to scale faster.
Okay.
And you had a question yesterday, as I think you heard in the video, I think it's north of 50,000 MAU, but I didn't get a response back from my data scientist. Yeah. But it's used over, I think it's used over 500,000 times a month, if that helps.
Sorry, Bo and Kaisa, could you repeat the question, because there are more listeners today?
Sure. I was asked the MAU, which I don't have a response for her yet. I'll get it to her when it comes in later today, but I think it's north of 50,000 MAU, and I think the app's used approximately 500,000 times per month.
Okay, great.
Any more questions?
Hey, Bo, it's Jerry Lynn. I have a quick question, because I was, very, intrigued by your presentation. The part where you talked about, as far as being able to have other digital therapeutics or other, pharmaceutical therapeutics kind of participate in your pool of folks who subscribe to SoberGrid. Could you talk to me a little bit more about that? Like if another digital therapeutic, say, that was indicated for trauma, if they wanted to kind of it sounded like they could access your
Yes.
patient.
Yes, so we're building, for the last couple of years, it's funded by the National Science Foundation. We've been building a back end that allows for clinical trials to go on. Since we have such a large and concentrated membership, it's attractive. It could be attractive for a company like some of the entrepreneurs that are on here today. If they wanted access to do a clinical trial, they could use our software and enroll our members in order to do that. And then beyond that, afterwards, for those that show to have strong efficacy, we could even work to help commercialize that product if an entrepreneur wanted us to. Likewise, let's say that you're a pharmaceutical company and you want to run a clinical trial, you could work with us and use the software that we're developing to access our members to run a clinical trial. And that research or clinical trial management software is part of this learning health system that we're contracted by the National Science Foundation to build. Did that answer your question?
Yeah, perfectly. Thank you so much.
Okay. You're welcome.
But that actually opens another question for me. So I understand that if the clinical trial arises, there's huge issues with informed consent and then going back. And if I signed up for an application for support and now I'm being, approached to be part of that raises a lot of ethical issues that I don't need answered right now, but I would ask you to consider that if it's not the sole intent initially, that it could be problematic after the fact approaching the participants. And maybe it's not an issue. I approach things from that lens, working within the clinical trial space, that it's just a real, it's a highly regulated area. So I would question that.
Yeah, I mean, I'd be happy to chat with you about that offline. We have a pretty large team of people internally and externally that have deep expertise with this, and I don't think that specific question has came up. So I think that the concern may be addressed, but I would need to rope in my research and clinical trial team members to sort of chat about that more.
Thank you.
Thank you. Thank you so much, Bo. And let's go to the final presentation before our brief break. It's going to be Richard Hanbury with Sauna Health.
Hi there, my name is Richard Hanbury and I'm CEO of Sauna Health. I'm here today to talk to you about prevention, mitigation and treatment of opioid use disorder. My journey into this area started in 1992 when I was driving a Jeep down a road in the Yemen near the capital Sana'a. I was forced to make a split-second decision and drive my Jeep off a bridge in order to avoid a head-on collision next to a petrol truck. My Jeep went down 60 foot into a drive riverbed and crumpled up like a Coke can. That left me with spinal injuries from T8 to T10 and a torn aorta and a TBI. I was medevaced back to the UK. I was in a coma and out of a coma, and I was clinically dead for 8 minutes. And all of that resulted in a nerve damage pain problem that was so severe that I was given a 5-year life expectancy. I was put through the standard of care, which largely hasn't changed in 28 years. It starts with opioids, goes on to include gabapentin, implantable devices, external devices, and eventually, as a last-ditch resort for suicide prevention, it is here, have some mindfulness-based stress reduction. Now, obviously, this didn't work for me, so I started to look for my own solution to try and figure it out. Obviously, in this audience, you know already exactly how bad the opioid crisis is, otherwise we wouldn't be here. Now, the challenge with chronic pain is that it combines multiple compounding comorbidities: pain, anxiety, depression, and sleep. And if you were to talk about fibromyalgia, then you're adding in PTSD. And then if you're talking about pain within a military context, you're nearly always adding in TBI, traumatic brain injury, as well. So the market need is for an effective non-drug pain solution tailored to the individual, treating all comorbid symptoms, non-addictive and clinically validated. This is what we have with Sana. It's the first medical-grade non-drug solution that uses audio-visual technology to create specific patterns in the brain that produce a very deep level of relaxation. The device uses collection of data from the headset itself and combines it with subjective data entered by the individual to, over time, create versions of the device which are tailored for each individual and each session. In audiovisual therapeutic wearable, we have a device that has clinically been shown to reduce anxiety by 45%, 20 to 40% reduction in pain, and a 49% reduction in depression, as well as improving sleep quality. So how does it do all this? How did I get to the solution? Well, when I first tried to meditate, I realized that getting into that state when I was already in pain was a really hard task to achieve. But when I watched a movie, it flipped me in and out of what we would now call a flow state. And I realized that the same way that VR has limitations, the idea that I needed to produce was a way of reliably, every single time I use a device, be able to get myself into that state. So I looked at all the research into meditation and how meditation changes long-term activity in people's brains and see if I could reverse engineer that process. On the right here, you can see an EEG that's looking at the left and right-hand side of someone's brain. And all of the long-term meditators ended up with this balanced left-right hemisphere on a standardized 4-minute test going through 6 different cognitive functions. My brain, as with most people with severe pain and severe anxiety, has very big disparity left to right. Now, when you take opioids, you are just simply masking this underlying problem, leaving this dynamic in place. So I built the first audiovisual neuromodulation, and once it fixed this disparity for me, it actually wiped out all of my nerve damage pain in 3 months. Prior to that solution, I had used the maximum amount of opioids that they would give me in hospital and got no relief. And with that level of pain and the sickness I felt, by the only way of relieving that pain is making myself almost unconscious with opioids, would have led me to not want to be alive much longer had I not actually believed there was a solution when I left hospital. So I was very lucky to already have that solution in my head, or that there was a solution. So audiovisual technology turns out to be the only way in which you can recreate this hemispheric balance. And the reason for that is that any drug solution is going through the blood-brain barrier and affecting both sides of the brain equally. When you attack this problem from an electrical standpoint, you've got to go through the skull, and that gives you the issue around the non-conductivity of bone tissue. You can address some of this imbalance with TMS, with big magnets, but then that gives you the issue of not being able to do it frequently or often enough without someone coming into a clinic. So anyway, so this allows us to go after the multiple comorbidities, pain, anxiety, depression, sleep, and allows us for at-home use, low cost, and no side effects. So in the various clinical trials we've done, the first one was a 75-person study with double relaxation, triple reduction in pain, and improved the high-frequency component of HRV by 5 times. That was showing a very strong autonomic nervous system deactivation. This is some of that data in detail. And then the next study we went on to do was an opioid use disorder study. We took 8 people in a clinic with PRA Health Sciences led by Lynn Webster and put those people through cold turkey withdrawal. We got an overall reduction of 37% in anxiety, and this topped out at 45% at the very worst point in the withdrawal process. This was done on a sham-controlled randomized crossover. With the opioid use disorder study as well, we got a desire to use drop by 38%. This was also mirrored with results with cows and sows. We then did a fibromyalgia study. This demonstrated a 5 times improvement in the quality, a 45% improvement in the quality of life, which is 5 times quality of life improvement that you can get with Lyrica, which is currently the best performing drug. Lyrica, by contrast, has 80% of people who start taking it stop taking it because of the side effects, and we've had 85% of people continue to use the device after the end of the trial, and those results are still maintaining at the 1 year mark, which is where we are now. So fibromyalgia is our go-to-market. We're aiming to be the first FDA-declared device for fibromyalgia. It affects 10 million people, and we'll be going after a subscription model. So our go-to-market strategy is in fibromyalgia to start off with, to first with the clinical trial at Duke, which is already underway, and a 1,000-person user study, which we've already started. We have so far seen an overall average reduction in opioid use of 30% during the fibromyalgia users from the first study. So this is how we're going to market: direct-to-consumer, physician recommended, and then reimbursement. These are the other studies that we've got going on. The most important one here, probably from the opioid perspective, is the post-op pain study at Penn. That is subject to an NIN grant that we've applied for, that is looking at reducing opioid use and pain in post-operative pain for total knee replacements. Obviously, surgeries and post-op pain is one of the largest causes of eventual overdose from prescription opioids. So this is the roadmap for sales for the company. This is a team. I've been at this for 26 years now, totally. And Tasha Bond, our COO, is 20 years medical experience with Forex. It's one of which she did with Steve, our CFO, who's been the CFO of a startup and an acquirer and a VC. And Jeff Bauer comes to us from Achille, has 10 years of digital therapeutics analytics experience. So in terms of the prevention and mitigation and treatment of opioids, the most important things that I've spoken about that I want to highlight are: one is prevention, cutting down opioids by having an alternative to opioids from surgery onwards and in other types of pain. But that study at UPenn will prove that out. Mitigation, the two 120-person RCTs that we've already got underway are our study on fibromyalgia at Duke, which we already talked about. And we also have another study at neuropathic pain at Mount Sinai, which is also already underway. Our initial approval, FDA will be a de novo from the Duke study, and then the self-predicated 510K will be the Mount Sinai study. We've also logged the IP for addiction for this device. And then last but not least, as a follow-up to the PRA Health Sciences study, we are applying for a NIDA grant in April to confirm the use of the device in the the treatment of opioid use disorder. So thank you very much for your time today. It's been my pleasure to be here, and I look forward to hearing questions later on in the session. Thank you.
Thank you, Richard.
My pleasure.
Any questions from our jury?
Yeah, I can go. If you could, I would appreciate if you could walk me through the unit economics so I better understand like the margins and the business model.
Certainly. So the device itself, the total COGS, including the initial customer support, is going to be sub $100 by next June, because we're producing a new device, the new version of the device. And then we're accounting for a quarterly cost of about $60 a month for ongoing customer support and care. And basically, we're testing the market first at a $50 per month subscription. And we are under reimbursement discussions at $100 a month currently with Anthem. So those are the two options. So currently we are on market as a wellness device under a 513G. And that's where our first OUD customers have actually come from, just buying us because they've seen the wellness claims and then bought. And that actually then led to a conversation with MindMed about the drug device combination for IUD.
Okay. Thank you.
I have a question if no one else has a question. I see your pipeline being very broad, and I keep pushing you on this, but what you're saying fibromyalgia is the first indication?
Yes, fibromyalgia is the first because we're closest to our FDA approval for that. And then we're basically going down indication as and where we have either partnerships in place to help us scale, or other route access to market. So opioid use as an example, there have been plenty of startups. I mean, there are a couple in particular that I've been told about that had good tech that failed because they couldn't reach the sort of much broader fragmented OUD market. And so we made a decision early on that we would partner in areas that the distribution and scaling was harder, so that we could make sure that we could focus on production of the device and making the system better, and then rely on partners for that scaling. That's how we are aiming to go after multiple at the same time, but we're not. The only distribution network we're building is for fibromyalgia.
Okay.
The other areas we're looking at all have good distribution networks with partners that already have very strong market share. And so we're going down this strategy of partnering in those different areas.
Very important, I think. It looks overwhelming otherwise.
Yeah, no, totally. And if we were trying to market to different areas without partners, it would absolutely not be possible to scale at the scale we want to. But the thing is that, I mean, there are so many areas where so for me personally, the device was a total fix. 3 months and done. And there'll be small subsections of spinal cord injury pain, TBI pain, and phantom limb pain, where we will be hopefully like near total fix. There are all sorts of other areas, and AED is a really important one, where we will be a tool in the toolbox. So if you think about things like cognitive behavioral therapy and what you heard from Rohan from Leaf, they are behavioral change and behavioral upgrading. And we are basically an emergency rescue med as and when someone needs a increased boost of anxiety. So I think we fit very well in a whole bunch of other people's toolkits. And that's why for us, it makes much more sense to go down that partnership route where we are tools in the toolkit.
Wonderful. Thank you so much, Richard. And that concludes the first section of our finalist pitches. And we're going to take a break now for 15 minutes. We'll meet back at 10:45 Eastern Time. And we're going to hear from our patient speaker, Lisa Smith. Thank you, everyone. Okay. We're all back, and welcome back to the next section of our innovation challenge. And we're going to start this pitch session by hearing from our patient speaker, Lisa Smith. Welcome, Lisa.
For these 2 days. What an incredible experience. Thank you to Lightbulb and to Orexo, all the judges and all the participants. I got sober 16 years ago, about 16 and a half years ago. And what if I could have the split screen? Oh, I'm sorry. Can you see me now?
Still waiting to see you. We saw the beautiful flowers.
Oh, I had it. Can you see me now?
No.
I see me on mine.
Saw you perfectly when you were part of the jury earlier.
Now I see the flowers.
Yep.
Let me see what I do here. So, I'm sorry. Oh, it was disabled somehow. It says I can't start my video because the host has disabled it.
Let's see, Kinza, if we can allow Lisa to show her video.
Okay. How's that? Can you see? No. And I see me. Okay. Okay, I see it here that it's sharing, so I'm going to stop it and start it again. Now it stopped, and now I'm back on my screen. Sure. Okay.
Let's see.
Can you see me and hear me now?
Yes.
Oh, good. I will try to be briefer in order to not go over time, but everything's good now?
Yeah, you're kind of yeah, we can see you. We can see you.
Am I at a funny angle?
Yeah, but you have to turn now. Now we can see you
better?
perfectly. Wonderful. Your bandwidth seems to be low. That's what it is. Anyway, welcome again, Lisa, and we're so happy to have you here as our speaker.
Thank you. So as I was saying, I really appreciate it and I'm honored by it. And I cannot believe the kinds of things I'm seeing and hearing. Just to give you my story and, how this all fits together. I was, like many people who struggle with coexisting mental health disorders like anxiety and depression. I was a kind of an anxious, nervous kid. I grew up in a great house in suburban New Jersey. My dad was a judge. My mom was a teacher. There was not anything that happened, any trauma, but I was always dark and fearful, anxious always. And as a kid, I realized that I got relief from those feelings through food, specifically sugar. Food was the first substance I abused. So that dopamine hit to my brain was something I didn't realize as an 8-year-old was helping me, but it was giving me relief. And so it wasn't surprising that when I got old enough in my early teens to find other people to drink with, I tried alcohol and felt like, this is it. This is wow. Like the sugar's great, but this is really what makes me feel okay. And I was always a good student, and also in the home, there was cocktail hour all the time, but not abusive, nothing like that. My grandfather on my mother's side did die of cirrhosis of the liver from alcohol. And so it was in my family. And I was an A student. I went through school, started in high school. I would drink to blackout on the weekends, but I ran around with a crowd that did that. So I always say that alcoholism is not contagious, but it does run in packs, and you kind of find your people all along the way who normalize the kind of drinking you want to do. So for instance, when I was in college, I would wake up out of a blackout, we'd all be laughing about it, and we'd all be trying to piece together the night before. So I didn't think there was anything wrong with it. In fact, I thought that it was helping me, that it was something by shooting the lights out on the weekends and, by sort of the work hard, play hard, I was letting off steam that gave me the capability to go in on, Monday and start really focusing on my books. I went from there to law school where the same happened. And again, it was not an every night thing for me. I'd certainly tried recreational drugs and enjoyed them, but they were not what I really looked forward to. And, again, it was, I was at the top of my class in law school. I was on the law review. I was an editor on the law review, and things were fine. But my drinking was my way of managing stress, of coping, and of taking away that anxiety and those dark feelings, like from when I was a kid, that still persisted. Then I won sort of the big prize and got a job, one of the coveted jobs at a big global law firm in New York City. And when I came into the practice of law, between my genetic predisposition and combined with my undiagnosed, untreated, unaddressed underlying depression and anxiety that I was self-medicating, when I added in the routine of a, stressful, pressure-filled, exhausting, life as a junior associate, that's when it really took off for me. And I became a nightly drinker as a first-year associate at a law firm. Fast forward, it began what was a 12-year spiral downward for me. which again, by finding people and ideas that could normalize it and rationalize it, I went from a nightly drinker to finding people who like to drink at lunch. So then all of a sudden, okay, it's okay, I drink at lunch. And then, but saying I never drink in the morning, and that's, you know, the real alcoholics, until the day I had the worst hangover imaginable. And I knew I had to drink to get to work for this meeting because it was the only thing. This is about a year and a half before I got sober. So more than 10 years into this descent. It was the only thing that would calm my body down. And I had transitioned years earlier from the practice of law onto the administrative side, doing business development. I had big jobs. I never even got a negative performance, a comment on a performance review. Everything was fine at work. And I thought when I started in the morning, this is okay. You know, this is terrible. I'm not going to drink in the mornings, but I'm going to do it this time because I have to get to that meeting. I can't miss that meeting, and I'll get this under control, right? It was a constant, you know, thinking of, you know, why wouldn't I be able to get this thing under control? I've been able to get everything else in my life under control. What's the problem here? And, you know, the answer was I couldn't get it under control. So instead of stopping drinking in the mornings, what happened was I started using cocaine on a daily basis to balance out the negative effects of like the slurring and the drowsiness from the alcohol. That was what my last 18 months of using were. It was around the clock, 24/7. I couldn't get out of bed without drinking. And, you know, I was circling the drain. Still, I got a nice raise and bonus the month before I got sober. And, you know, everything was fine at work. But I was certainly not performing at the level I could have. And a parallel to that, and I think this is important for what we've been talking about today, parallel to that, you know, downward spiral physically and in terms of addiction, there's a second spiral that takes place. That is that spiral of fear and shame. And I lost all my self-esteem. I used to wake up in the mornings and just, you know, like curse that I even woke up again. I would look at myself in the mirror before I went to work and say, I hate you. It was a horrible, horrible thing. And finally, one morning, I was on my way to work, leaving my apartment in New York, and I was overcome with this feeling that I believed in that moment that I was having a heart attack or a cocaine overdose. I now know that it was a panic attack. But in that split second, when for all the days that I had said, I'm not going to, you know, I don't want to be alive. In that split second, something snapped in my head and I said, wait, I don't want to die right now. And I went into my apartment and called my doctor and said, I need to go to detox. I know I need a medicated detox. And he was like, I don't understand why you would think that. And I gave him like 3 facts and he said, okay, you're going to go. And I landed without any research at the worst psychiatric hospital, the worst detox unit in the city. It was very, very scary. And that's why I always tell people, don't ask your gastroenterologist where to go to detox because he doesn't know. And this reflected 2004 reality. I had no sober references, no place to reach out for help, none of that. It started my journey, and I was very desperate at the time I got sober, and I grabbed onto it and went, I did go to outpatient rehab at night after I got a detox because I refused to go away to inpatient because I didn't want my law firm to know that I needed some kind of leave. I feared the stigma. I know I talked about this a little bit yesterday. The stigma is very real. And since that has happened, I'm a 12-step person and I grab 12-step like crazy. And for me, that has been the answer. There are many paths. There are other paths. But what I have been fortunate to have the opportunity to do is to write my experience down, which was very cathartic. My book, Girl Walks Out of a Bar, chronicles this whole story. And from that, I have been able to reach out to others to, those feelings of shame, fear, regret, everything. You feel so alone and so isolated when you're going through it. And I wanted desperately for the next person to know that they are not, in fact, alone. And that's why I wrote the book. And that's why I go around and speak at law firms and law schools, and I do coaching, and I have a podcast, Recovery Rocks, with a millennial, and we talk about these things. And, you know, to hear today, the huge message I get out of today has been that, you know, not only can people know now so much more than I did that they are not alone, but there are people like all of the patient entrepreneurs who are dedicating their lives to changing the next person's life and to changing the next person's trajectory. And I'm going to wrap up because I know we're tight on time, but the things that I'm seeing today give me more hope than I've ever had about what's going to happen, because you are all truly going to change the world and are changing the world with what you're doing. And just want to say thank you so much for having me, including me in this day. And I'm honored, and best of luck to all.
Thank you so much, Lisa. Thank you. That's really, really beautiful, and really thank you for sharing so much. And it's really inspirational. It's wonderful to hear this in the middle of these pitches, because it makes it all so very relevant. Thank you.
It is, yeah.
So now we have to go back to our pitch competition, and I welcome Swati Survey with Light Sprite.
Thank you, Karen, and everyone at Orexo for giving us the opportunity to share our work. We are incredibly excited to participate in the summit today. We know video games captivate. Can they go one step further and improve health? Lightsprite builds games to help people manage chronic health conditions. Clinicians and players rely on our data insights. Our clinically validated mental health video game, Cinesprite, is the first to win a U.S. Surgeon General Award and the only one recommended by clinicians and payers today. There is a lot of stigma associated with addressing mental health and overcoming addiction issues. It doesn't have to be, though. Games are fun, familiar, approachable. They focus attention, inspire, and empower people to learn skills on a long-term basis. They also create strong community ties. At its core, Cinesprite is a self-help tool that empowers people on a long-term journey of self-discovery. It's a safe place where they can explore their emotions, understand their triggers, discover what evidence-based techniques work for them, and learn those skills. We've won over 20 Global Health Innovation Awards, including recognition from these organizations. We are considered one of the leaders in digital health and digital therapeutics. Our traction includes launching and establishing validation of our mental health video game, Cinesprite, determining the economic impact of our clinical results, validating the reimbursement pathways, and securing investments from strategic partners such as Bayer Pharmaceuticals. We were selected from a pool of over 750 companies in 65 countries to take part in Bayer's G4A Growth Partnership track. 100 reviewers evaluated our clinical evidence, market adoption, market opportunity, and strategic alignment to Bayer's business. We align with the digital therapeutics and integrated care initiatives. Yet another validation of our leadership position in these fields. The final jury was 20 patients. We were chosen because we were empathetic to their needs, or we were a solution that their family members could use. With minimal sales optimization, we realized revenue, established a robust sales pipeline, and are now receiving an increasing number of inbound requests. I've focused my career on developing technology that inspires and empowers patients to take care of themselves. As a healthcare technologist, I have observed that individual motivation is the key to improving a person's health. In 2013, I read numerous peer-reviewed research papers that showed gaming improved outcomes, but I found few commercial solutions, so I created Lightsprite. In 2017, I met Eric. When he became my significant other, he confided in me that he had depression. He didn't like going to a counselor. He started using Cinesprite to see if it could help. Eric showed his psychiatrist he was using Cinesprite. She finally agreed to reduce his medication dosage. With Cinesprite, Eric now had a tool that would let him explore his emotions and learn effective coping skills. I'd never met anyone with a substance abuse disorder, so I didn't know what signs to look for. I had attributed the binge drinking, the lack of energy, and disconnectedness to extreme stress. After a disastrous New Year's Eve, Eric finally acknowledged that he was an alcoholic. And suddenly I found myself a caregiver while being the CEO of a startup. Eric now used Cinesprite on his path to recovery. The gaming aspect was immersive and visually compelling, so it felt more like a place. This engaged him deeper and forced him to focus, something that is hard to do as an addict. Cinesprite became the catalyst for him to learn new skills. He signed up for a meditation class, and until then, he had never tried it before. Eric is among the 40 million Americans who suffer from anxiety and depression. It's a condition that impacts many people from all walks of life, has a huge cost, and the treatment options are scarce. There's a high comorbidity of poor mental health and substance abuse. Among the data points, 50% of Americans who experience a mental illness will also experience a substance abuse disorder. Cinesprite is a game-based self-help mental health digital therapeutic that supports the emotional and clinical journey of the chronically ill. We are a trusted support pillar during their greatest hour of need. In a clinical setting, we have worked with a range of diagnoses, including substance abuse. The game is based on Bandura's social cognitive theory, a commonly accepted framework by clinicians. A player chooses from a range of activities or mini-games that sit on top of this framework. These mini-games are a unique combination of evidence-based treatment methods and mindfulness strategies, including meditation, journaling, diaphragmatic breathing, physical activity, and gratitude. Some mini-games, like gratitude, allow a player to connect with their support network. An important element in Cinesprite is the game's protagonist, Socks the Fox. Socks is a peer to the player and addresses their emotional needs. Socks becomes a Zen master by teaching players effective coping skills. Socks guides players through journaling, exploring emotions, meditation, breathing, and the world expands as they learn these skills. Doors literally unlock and open as the player continues to work on themselves. Cinesprite appeals to a broad age range, which means we are great for families. Our unique experience has resulted in above average retention that makes it ideal for long-term recovery. We are also seeing certain cohorts, such as men over 50, with even higher retention rates. Our trusted self-care tools and unique patient data were redefining care even before COVID-19 and have proven more valuable since. We've reached difficult to motivate populations, including Medicaid patients. Here's what a few players have shared with us. Cinesprite helps Hilda with loneliness through journaling and Socks. Suzette finds it very convenient, a real game. She loves the meditation. For Darren, it's a healing tool. Socks is calming, a digital companion on the healing journey. The data insights from our clinical dashboards have already helped clinicians remotely monitor patients and deliver customized care beyond the clinic walls. One clinic started teaching Medicaid patients about meditation after our reports showed they were trying to learn the skill on their own. We collect unique player-generated data set that includes text, voice, image, and video. We can construct digital biomarkers and build predictive models that can identify at-risk patients. Here's what clinicians have said about the ability to customize care. Anne sees that the report shows the game is with benefits. For Nicole, the data showed how treatment was progressing and her client felt more supported. For Brian, he observed his clients achieving lower scores faster and had better application and retention of concepts. For the first time, he could customize strategy. Independent studies conducted by the Ohio State College of Pharmacy and Madigan Army Medical Center have clinically validated Cinesprite. Health economists at the University of Washington determined these clinical results had an economic impact of 17 QALY gains, and primary care providers could realize an additional $22,000 annually per 1,000 patients. Business differentiators that our customers have identified include clinical validation, clinical acceptance, reimbursement, and economic impact. Our approachable, non-judgmental, experiential game-based format drives long-term engagement. We span the care continuum. We engage difficult to motivate populations like Medicaid. Our broad appeal and range of coping skills that we present make it ideal for families to play together. We are driving innovation in our go-to-market strategy. We have validated reimbursement in 4 care settings and intend to be prescribed. Pre-COVID, our core customers were payers and providers. We charge in PMPM and shared volume licensing, and buyer support includes accelerating these conversations. Post-COVID, we are now receiving interest from employers and a robust consumer demand. We've built a clinically validated product that patients and clinicians love and have realized revenue. The use of proceeds will be applied to complete key hires, further product development, and continue to build our evidence base and launch new digital therapeutic games. We are leaders in the new field of healthcare entertainment. We are a group of subject matter experts in gaming, healthcare, and consumer products. We wrote Nike's first wearable technology patents. We manage the largest portfolio of mobile health apps for the Department of Defense. And we manage data science teams for the State Department. We built consumer-facing experiences for global brands like Disney and American Greetings. We are supported by a board of clinical experts, healthcare and gaming executives, and entrepreneurs. LightSprite gets people engaged. Engaged people get better faster. Thank you.
Thank you, Swati. Great presentation. I'll come
So
back
this is
to
Jeff. Can I ask a question?
Absolutely, Jeff.
Great, thanks. So just curious about your revenue model to date, where you are, and your forecast over the next couple of years with us.
Sure. Right. Our revenue model to date has been working through the payers and provider channel. It's been a PMPM model that's typically what they want to work with. Right now, our focus is moving to, we're looking at D2C, just given the robust demand that we've had with COVID. So we're offering a freemium model for D2C, and we're also looking at the employer channel as well, because we're receiving a lot of inbound requests.
Where is your revenue currently?
It's been through payers and providers.
No, I know, but dollar-wise, I'm sorry.
I'm happy to disclose that at another time. I don't want to do that on a public forum.
Okay.
So it's company sensitive information, but we have realized revenue.
Okay.
And then moving forward, though, we're looking, once we start get adoption from the consumer and employer channel, that'll also accelerate the conversations we're having with the payers and providers too.
Thank you.
I have a question. Hi, it's Jerry Lynn. So I like the behavioral modeling with Socks the Fox. I think that's definitely clever because, what it's doing is, teaching people how to appropriately use mindfulness techniques and things of that nature. So I think that's cool. I have a few questions though, just regarding, some outcomes. I just have outcome questions. The first one is, do you have data that can demonstrate how often people are actually using the program, and then how often they've used it, and then what the recommendation is on your end of how often they should use it? And then after you answer that, I just have a couple of follow-up questions that would support those previous questions.
Sure. No, it's a great question because, and it kind of goes back to your question of yesterday around like what's appropriate usage. And as a healthcare technologist, that's one of the things I think you have to be very, very mindful of, because you can build technology to drive all kinds of behavior, right? We talked about this, like there are even non-gaming experiences right now that are very addictive. So it's about what's the right level of engagement. And from the beginning, we worked with psychologists and social workers. And so what we determined is if they can use it about 2 to 3 times a week, and 5 to 10 minutes a day. Casual games are typically used and played no more than 5 to 10 minutes at any given session. And what's really exciting is that with the first beta version, that's exactly the targets that we hit. We recommend that they use it once a day, but naturally what we're seeing is about 2 to 3 times a week, about 5 to 10 minutes a session. So, which is great. because it's a tool that can then easily fit into someone's life.
Yeah. You can do it like while you're at the car line, picking the kids up. So here's my yeah, exactly. So here's my two follow-up questions. How long, because I know you had mentioned Medicaid, and I'm happy to see that population of folks has adapted to this and has received it well. How long do you give access to your program? What's the length of the expiration of the license or access to the program? And then the follow-up to that are residual effects clinically. So if you give me access for 3 months, how long, is there any data that shows, the long-lasting clinical effects of the program?
Sure. So the access to the program, so one of the things from a social mission perspective is we've always, and that actually goes into the pricing, even on the D2C side, we always wanted to have something available to somebody. So technically, from a D2C model, there'll always be something available. We weren't charging, even when we were working with payers and providers, that beta version that we had out allowed us to collect the clinical data. But from a provider perspective, what we would charge for is the access to the data and the reports. So that's what they were paying us for. And so if we were working through, like we worked with Samaritan Daytop Village and the Jewish Board in the Bronx, or when we worked with Assurance Health and Wellness in Arizona with the Medicaid population there, or Passport Health Plan, it all depended on the license and how long did they want their patients to have access to it. So that's a business decision. Regarding residual effects, we're actually we're looking at revisiting the data that we have and possibly publishing a second paper to see the 12-week impact that we've had. So far, qualitatively, what I see, like with Suzette or Darren, we see them engaging, and I think I showed you the data points. We're seeing the engagement over time, and what's also even more fascinating is we don't actually ping them. There aren't any notifications or anything they're getting. Okay, so we haven't even built that level of engagement. This is all natural. So it's really about what we're trying to do is activate patients in a very, very minimal way. Can we get their own motivation going without any kind of external stimulation device or even, how should you say, nudges, if you will, right? So because you want to do that appropriately, and when is the right time to do that?
Thank you. Thank you, Swati. Yeah, we got a break there.
Okay.
All right.
Aaron,
thank you so much. Thank you. Okay, we need to move to the next finalist. I'm sorry, Aaron.
It's okay.
And the next finalist is Tyler with Jana.
Hi, good morning and welcome. My name is Tyler Matheny and I'm the co-founder and CEO of Jana. I want to thank the judges and panelists as well as Lifebulb and Orexo for selecting a company that at the time was 5 months old as a finalist for the 2020 Innovation Challenge. I founded Jana because I nearly died finding a path to recovery. I had incredible insurance, the support of a loving family, a promising career, and access to world-class treatment. So how did that happen? This morning, I'd like to do a few things. I'd like to share part of my story as well as what happened, what it's like now, and why we founded Jana. So what is Jana? Jana is an acronym that stands for You Are Not Alone. It's a technology platform that bridges the gap between curious and sober and is designed to help people find a path to recovery. Getting sober was one of the loneliest and most difficult experiences in my entire life. I didn't have a sober social life. I had no idea where the good meetings were. I was told to get a sponsor, but I wasn't told what to look for in one. So here I was, leaving one of the best treatment centers in the world with no idea what to do next or even how to find it. So we believe that my experience is not unique and that many people struggle with the same questions. So our primary purpose is to connect addicts and alcoholics with the tools, knowledge, and community that the collective experience of millions of sober people shows is effective. Ultimately, we founded Jana because we were tired of watching people die trying to find a path to recovery. It's so uncomfortable, isn't it? We don't like talking about the young people that are dying every single day, the father that's lost his children, or the woman that's been absolutely devastated by this disease. For as much as society celebrates the addict that's overcome their addiction, we do an equal amount in vilifying the person that still struggles. We've gone to great lengths to hide them from family, friends, and coworkers. The hardest journey for any addict is to admit powerlessness, but it's in that surrender where we find absolute strength. So our mission is to inspire and empower people to live a happy and sober life, to change the way that addicts and alcoholics are perceived and treated, and to demonstrate through our own lives just how good a sober life can be. So our intention with Yana is to present the 12 steps, both in terms of description as well as practical application as they were originally intended, quickly and with the aid of a sponsor who has recovered, and then to leverage modern technology to increase our reach 10x. Now, if you haven't surmised by now, Yana is unapologetically pro-AA and the 12 steps. But AA today barely resembles what the founders had envisioned in 1938. There was no 90 and 90 or easy does it. There was, you've got 30 days sober and we need your help down at the Salvation Army. It's time to start working with others. So Yana combines the reach of modern technology with the battle-tested methodology of the 12-step program and helps people find a path to sober living. Everything in our platform is predicated on the belief that anyone can recover. From yoga to meditation to vetted 12-step meetings, that is Yana's singular objective. And it doesn't matter if they came in with a jet or a tent, no matter what their present circumstances are, they can get well. So just as Bill and Dr. Bob realized in the early days that the power of AA and its message was just as effective through the mail as it was in person, 2020 is proving that recovery is possible, effective, and stands the test of time by leveraging the internet. So why now? Despite decades of effort from healthcare workers, policymakers, and researchers to solve the accelerating problem of addiction, little has resulted from the effort. Drug overdose deaths have tripled in the same span of time that the war on drugs was supposed to have made such strides. The United States has the highest documented incarceration rate in the world, many of which are for nonviolent drug offenses. We go to great lengths to hide the very illness from the people that are in the best position to help: family, friends, loved ones, doctors, clergy. Businesses lose an estimated $740 billion every year in the form of lost productivity, ballooning healthcare costs, and crime-related expenses. So a failure to act is complicity by proxy. There is no other time. But for me personally, the answer to this question is a lot more straightforward. I'm alive today, and I believe the reason for that is so that I can help others recover. Now, the biggest issue with every other platform is that once you sign up, there is no direction. What do you do first? How do you find a meeting? Are you even in the right place? So we knew from inception that we wanted our platform to be incredibly simple and have a flawless user experience. But as with any platform, there are definitely limitations, ones that we hope to alleviate as we raise our seed round of funding and continue to build. Today, people can join one of two ways. They can be granted access by an existing member, or they need to be approved by an administrator. The reason we don't allow anyone to sign up is because it gives us greater control over the experience and will help us facilitate the strongest results. Everything Yana does is in support of a three-part answer to a three-part illness. Unity, service, and recovery is a direct response to the physical, mental, and spiritual. From vetted 12-step meetings to yoga and guided meditation, Yana seamlessly integrates with some of today's most popular platforms, including Facebook, Zoom, Spotify, and Google Meet. We want our community to love recovery. We want them to share the progress that they're making and ultimately to use the platform to help others get better. So, founded in April of 2020, Yana is truly in its infancy, and what you see today is a fraction of what we are capable of doing and what we have planned for the product roadmap. From strategic partnerships to virtual support services, our goal is to eliminate as much friction as possible for people seeking a path to recovery and to get them from point A to recovered as quickly as possible. As the world opens up again, so will Yana, allowing our online life to help shape our offline life. We're already seeing groups of people that met on the platform meet offline. It's a small but very encouraging start. So this slide was particularly hard for me to put together because we believe that every app and site in the recovery space has good intentions and is intended to improve the lives of addicts and alcoholics. But the general problem is that the cost can be prohibitive. They're incredibly broad in scope. I mean, let's just call a spade a spade. Fentanyl should never be in the same list as energy drinks. They offer a confusing user experience, and most importantly, they don't provide any guidance. An addict and alcoholic that's been badly burned by this disease is looking for one thing: hope. Can you really wake up in the morning and not obsess about drugs and alcohol? Will you ever recover the things you've lost through your addiction? Can your relationships ever be healed? Will you ever feel like you matter again? The backbone of Yana is the 12 steps as they were originally written, as they were originally intended to be used to overcome addiction. It's not self-help, it's not positive affirmations, and it's not meeting makers make it. It's work the 12 steps with the sponsor as quickly as possible so that you can start helping others. The combination of increased insurance coverage under the ACA and Medicaid, coupled with the opioid epidemic, is fueling demand for treatment. But this demand has also resulted in the entry of many facilities and sober homes that don't follow best practices and have dubious outcomes and poor quality of care. It's why fewer than 20% of people who receive treatment will actually make it to a year of sobriety. They don't know what to do. So let me be clear, the need for inpatient services is important and it's necessary. The safest way to detox is under the care of a physician. However, once a person has been detoxed, what do they do next? Where do they go? How do they find a sponsor? What makes a meeting good or bad? When I think of where Yana will be in a year's time, I am deeply encouraged, especially when I extrapolate the results we've already seen. From hospitals to institutions to governments, there is a huge need for solutions that show promise, and I believe that Yana is absolutely one of them. Since its launch, Yana has been able to offer daily meetings that are from some of the strongest recovery groups in the world. Additionally, Yana offers a 24/7 marathon meeting in conjunction with people in recovery from around the world, including Australia, Bali, Germany, New Zealand, and more. This ensures that we can offer meetings 24 hours a day in any time zone. The recovery community is incredibly fragmented and one that has been largely untouched by technology. Yana is going to change that. We will ensure that no matter what a person's socioeconomic background is, no matter where they are, they will find a place of support and understanding when and how they need it. Since our launch in April of this year, 46% of our community reported that they are sober, have worked the steps, and are now working with others. 26% reported that they are sober, are working the steps, and will begin helping others when they finish the work. This approach works. It's worked since 1938. Scaling Yana, we believe, will put a large dent in the problem of addiction, but growth will be intentionally slow at the beginning. Whatever our community becomes in the beginning will deeply impact what it is in the future. So our objective today isn't mass user growth, but recruiting people that can help others recover. Now, Yana has multiple options to become profitable and monetize the platform, but none will ever include charging members for access to our community. We do not believe in the monetization of addicts and alcoholics. Our model will include working with providers and businesses to bring their subject matter expertise to our community in the forms of paid sponsorships, as well as a standalone employee benefit for employers to leverage to save top talent. When Tudor and I met, we were both in active addiction, but at the time we definitely would not have called it that. Like many alcoholics, we long recognized the symptoms before we were able to accept the reality. Drinking is common in the tech world, especially at startups. It makes hiding alcoholic behavior incredibly easy. Tudor was my colleague, my friend, and my drinking buddy. After leaving that startup, I relocated with my family back to Austin. 18 months later, and totally unrelated to what we were each respectively working on, Tudor and his wife moved from all places from New York City to Austin. We reconnected, and not long after that, both got sober. It was through this experience that we first began to ideate about a web-based, self-directed recovery platform, and it was during the COVID lockdowns that we decided to build and launch Yana. Tudor and I were both at the precipice of a major life decision. We could either continue to drink until the bitter end, losing everything that we loved, or we could accept spiritual help. Now, how we found that help was very different from one another, but both included the truth that this is a fatal, progressive illness and that over any given period of time we would get worse, not better. A spiritual advisor that showed us how to recover, and most importantly, a social outlet that not only helped us reconnect with others, but also showed us how our experience can help others get sober. Once again, I want to thank the judges and panelists, as well as Lifebulb and Orexa, for allowing Yana to present as a finalist in the 2020 Innovation Challenge. I look forward to answering your questions, as well as hopefully meeting some of the other companies presenting today. Thank you.
Thank you, Tyler. Welcome back to the jury.
Tyler, I'll start. Thank you for answering the question about monetizing and providing it free for the user. I do have a question. A lot of what you're proposing, and I mentioned this yesterday, it feels as if you've taken AA, the spirit and principle of AA, and are now moving it digital, which I applaud that effort. That is forward thinking. But in thinking about a SWOT analysis, your biggest AA itself. How do you anticipate addressing that competition of AA that it's going to be based off of? I can already feel it, that people will have strong feelings whenever it feels like much of AA in a digital platform, and I would like to hear how you plan to address that.
Yeah, thanks, Aaron. You actually, so I think you called it yesterday AA 2.0, and I really had to think about that. It's really AA 1.0. In the first decade of AA's existence, the recovery rate was near 90%. 90% of people that were starting a program of recovery through AA were staying sober a year or longer. So it doesn't take a data scientist to recognize that we've skewed pretty far from what they had originally intended, which was this hugely powerful altruistic movement. So for us, it's at the very least taking a newcomer and saying, if you want what we have, we can show you how to get it. If you don't, that's okay too. We have people that come from all walks of life in our platform. As long as they could show someone else how they recovered, we make no bones about it. And AA, ironically, some of the people that I thought would be the biggest detractors from what we are trying to do, that are literally, speakers for the World AA Service Conference, have become some of our biggest advocates.
Okay, I also have a question regarding the business model. You mentioned that you will have a B2B business model focusing on enterprises, right?
Correct.
So how do you, I want to understand the size of the potential business and your forecasts going forward. So what have you forecasted within like the next 3 years for the business?
So the forecast would be nearly irrelevant in the sense that we're a 6-month-old company. What I do know is that it costs over $3,500 to replace a $10 an hour employee. It's well north of $250,000 to replace someone in a director level or higher. The problem is that most organizations, by the time they've identified someone that may have a problem with drinking or drugs, it's usually too late. They're usually either on their way out or have already been fired. So the idea here is to leverage Yana as a totally anonymous tool. But we have a lot of back-end analytics that we can provide to the employers to help them save top talent.
But what do you estimate you will earn on one enterprise customer?
So we estimate that we would earn between $12,000 and $15,000 annually per customer.
Okay.
Okay. Thank you, Tyler. And we will move to the next finalist, which is Marissa Barbieri with Competitive Solutions.
PRRX, a product presented to you today by Marissa Barbieri, CEO and founder of PRRX LLC. PRRX, a healthy connection. Click a button, find a peer.
Hi, my name is Marissa Barbieri, and welcome to my pitch on PureRx. PureRx LLC is the company. I'm also CEO of Competitive Solutions, a healthcare IT technology consulting firm for the last 25 years. We've been providing technology solutions all around the nation to our clients who are in need of new innovations, connecting data for a connected healthcare system. Let me tell you a little bit about PureRx, but before I begin, let me ask you a question. Would you go back to calling for a ride using the telephone, or do you like Uber? Well, PureRx is a new Uber technology platform used in healthcare settings by nurses, doctors, and community responders to connect patients to trained people with common experiences or survivors in the substance use world. The first launch of PureRx is used to find substance use peer support specialists. Let me tell you more about it. A client or patient can be in a hospital, drug court, urgent care center, police station, or any healthcare entity or location, and the caller would use PureRx and press a button to find a substance use peer or a mental health peer or a co-occurring peer a peer can help with both those. PureRx would then broadcast that need in text form to the area peers that were set up in the pool by the location, and the peer would answer with their availability. PureRx would then get all those responses and pick the best peer that matches the patient's needs. What's the value of peer support? Peer support yields lower relapse rates, according to SAMHSA, the Federal Administration for Substance Abuse and Mental Health. And in most states, Medicaid reimburses for peer services. Peer services are considered a critical component of a recovery in substance use. The impact of PureRx, well, we launched in 2019, and we have registrations in already over 4 states. Over 1,000 calls were processed in just 1 county alone, and every peer request is captured and responded to. In the first month, 0% of patients from one hospital were engaged using PureRx that were readmitted back into the hospital within 30 days. This is a critical metric for hospitals. Hospitals can be penalized for readmissions. PureRx also makes the discharge process more efficient. It reduces the time to find a peer from an average of 1 hour and 40 minutes to under 10 minutes. Think about it. If you or a family member or friend recently overdosed or need a peer, would you want to wait over 1 hour and 40 minutes to someone to get on a telephone? Or would you want them to use an app and call for a peer and know that they're going to be coming in 10 minutes if they're available? The first month that we were live, an agency reported that a hospital increased referrals 225% for peers. That means they asked for peers 225% more. Why? Because it's easy to use. The nurses no longer have to leave their ER station, go to a phone where they can hear the other person, and call around for agencies that might have peers available. We also believe the magic is in the match for long-term engagement. The patient could request a specific gender, language, or age, and more, and PureRx will try to find the best match. We have a proprietary algorithm that is in the core of PureRx, and we are very proud to tell you it is working beautifully for our patients today. Who are the buyers of PureRx? The buyers are hospitals, healthcare centers, primary care physicians, peer agencies, and other peer providers. A whole slew of healthcare entities are the buyers of PureRx. The goal in 2021 at the end is to gain traction 25 more states. In a single state alone, there are thousands and thousands of agencies and healthcare providers, potential users of PureRx. The revenue model, PureRx is a subscription-based model. A monthly premium fee is charged for access to the reporting and the analytics. The analytic dashboard gives the agencies an idea of the community needs, the type of peers requested, the time of day requested, the gender, the language, the age requested, and other criteria. So it's very critical. It provides insight that's not easily obtainable today in communities. The revenue, for example, of potential in a single state with over 2,000 potential user sites is $458,000 a month with the $229 subscription fee. We believe the potential revenue can reach over $500 million a year. In just 2 years, we could reach that number. So why did I create PureRx? I created PureRx because my son's great friend, and who I considered a third son, had a trauma after high school, and he fell into drugs, and he died at a very young age of 26. And it was riveting, his death, and I decided to put my energy into helping. So I volunteered my time, and I met the National Guard Counter-Drug Task Force, and I developed an opioid tracking tool in this boy's memory. And in doing so, I learned about peers and the value of peers. I asked the nurse, who helps the patient traverse out of the ER? They're just going to leave by themselves? She says, well, we try to find a peer for them, but sometimes we can't. So I thought, I'm going to do this. I'm going to create something, and PureRx was born. So we hope that you join us on our journey. We would love you to help us try to save lives. We're moving along, and this particular technology innovation is very critical to connect the peers and the bridgers to the patients so they can transition them into the community services, the vital services like food and housing, and they can help them get those needed services for their recovery. So thank you so much. You can reach me at marissa@pure-rx.com or on the website at www.pure-rx.com. Bye now.
Thank you, Marissa. Let's move back to our jury.
Hi, Marissa. I'm curious about so I see that hospitals and drug courts, which are typically institutionally funded, I see that they have a subscription. Is there any difference in the fee structure for them versus sort of a smallish community-run peer agency, or is the fee the same for every organization?
The fee is the same. There is a base free plan, which does it. So the plans are, there's a free plan, and then there's the basic and the professional plan. We sell the data, right? So they could get up on PureRx free.
Okay. Thank you.
Sure.
Yeah, I also have a question. So as this is an Uber-like business model, you have a two-sided platform, one demand side and one supply side. Which part of the platform do you think would be the hardest to attract in order to achieve a good balance in the marketplace?
So what's going to drive this is the callers. The hospitals are going to drive the adoption. The agencies will jump on. We've seen this with one of our states. The agencies will jump on because the hospitals will say, we will no longer be calling you by phone. We're going to be adopting PureRx so that we can improve efficiencies and create a model of efficiency within our hospital. The agencies are excited about it, but we see that what's going to drive it are the callers.
This is Aaron. I have a question. It's a follow-up from yesterday.
Sure.
The key part of this is the relationships that the peers have at the hospitals. We have a pretty robust peer support program here in the state that I live in. I guess what I'm hearing, what does this mean? Excuse me, I'm sorry.
Sure.
What does this mean for the pool of peers that currently exist in each state? Because each state has their own efforts going on. So if your product comes to Missouri, does every peer automatically get enrolled in that? And now that becomes the dispatch service, if you will, for the peers with the community providers and so forth. So on, can you explain that a little bit?
So, Aaron, if I understand your question, what happens is the locations set up PureRx to call the pool of peers. So if there's an MOU or memorandum of understanding between the location, let's say it's a hospital in your area, and peer providers that have those relationships, agencies that have relationships to go to the hospital will set up that agency as a pool provider in the area. So that's how the peers are controlled. You can't just register for peer as a peer in PureRx. You have to come on board PureRx through an agency.
So the only pushback that I would give on that is the counter argument to that would be all the peers, we have, let's say 1,000 in Missouri. If those agencies don't get on board with the product, you now have 1,000 out of work peers. In theory, unless those agencies come on board. That's just the only pushback that I have, knowing that that's going to be, that workforce issue is one that it necessitates all of the agencies come on board with your product for them to have job placement.
Well, to be honest with you, that's what we want to force, so that our patients get the care that they need, and they're not getting it now. What we saw was out of 10 patients
too got a peer showing up at the hospital. The agencies don't get the efficient communications that they should have. And so we want to force that move that the agencies would get on to the platform so our patients get the help that they need, because there's a lot of missed patients.
Marissa, I have a quick question. So, I mean, I think peers are great, and I think they're needed. My question is, somebody who's been severely impacted, let's say they overdosed on, an opioid, they're in the ER, not predominantly because they want to be, maybe they were cajoled there by a family member, and they're kind of they're not there yet. There's a lot of what we call AMA, people leaving against medical advice, especially at the emergency department. So my question to you is, how good are your peers in trying to work with someone who, may be significantly hesitant? How good are they in really doing that case management piece of getting them the help that they need, detox, inpatient, and striking while the iron's hot, because you have a very small window in order to get that person into treatment? So, my question is more like the functionality and the expertise of these peer coaches in order to get people the help they need at a very, very important time.
Right. So we don't have any control over they're not our peers, right? The peers sign up, they have to be certified. So they are SERPA certified, or they have mental health certification in each state. They have to be certified, and they follow the protocols that they would normally follow to address your question, right? So they're handling it now. When they sign up for PureRx, we make sure that PureRx in the algorithm picks certified first. There are provisional certification. Those folks, if they answer the call and there's no certified folks that answer, they'll get that call. They'll win the referral. But otherwise, the certified ones get that. So we care about the quality of peers getting deployed as well, if that answers your question.
That's what you can control, I think. Thank you, Marissa. We need to move to our next finalist. Shay Hauser with the U-Turn.
Hey, good afternoon. My name's Shay Hauser. I'm one of the co-founders of U-Turn. And on behalf of my partners, Elizabeth McKissick and Rich Jones, we really do appreciate the opportunity to tell you guys about U-Turn. So U-Turn spun out of a nonprofit in Greenville, South Carolina called Favor Greenville. Favor Greenville is a nationally recognized program that supports individuals and families struggling with addiction. Favor's done incredible work over the last 7 years. It was named Department of Justice Program of the Year in 2017, and is currently the only program in America, recovery program, that's being studied by NIDA for clinical validation of the coaching services. They've done incredible work. Elizabeth, Rich, and I all supported Favor. Rich is CEO, and Elizabeth was one of the original members of the founding team at Favor. Helped over 40,000 people. Learned quite a bit about addiction over that time frame. Through that, we created the idea of U-Turn, which is essentially the idea of taking what we learned at Favor, helping families, and scaling that digitally across the country, and doing that through technology. Now, all three of us are in recovery from addiction. I've been through treatment a number of times, 4 different times over the last 10 years. So I've got a very keen understanding of what addiction is and how we need to support it, along with Rich and Elizabeth as well. Let me give you a little bit of data, because I think this is important to help understand why we're doing what we're doing and why we're so passionate about it. 200,000 people die every year from suicide, drugs, and alcohol. 46,000 people die from suicide. So there are literally millions of people being impacted by the death of a loved one from suicide, drugs, and alcohol every year. Likely 2 million people directly impacted. Brother, sister, mom, dad, child, whatever it may be. The statistic that blows me away is this. There's 1.7 million suicide attempts every year in America. 46,000 are successful. That means 1.65 million people try to kill themselves every year and fortunately survive. But imagine their pain. And there are countless hundreds of thousands of non-fatal overdoses where somebody winds up in the hospital and is revived either through Narcan or some other way. 1.65 million people attempt suicide and live. If your loved one attempts suicide and lives, you are impacted. If your 18-year-old child overdoses and when you get to the hospital, they are revived, you are impacted. There are literally 10 to 15 million people in America every year directly impacted by the death through suicide, drugs and alcohol, and attempted suicide, or an overdose that winds up in the hospital. 10 plus million people. It means it's statistically impossible that it's not going to happen to you during your lifetime, and probably twice. I don't mean a friend. You get this, right? I'm not talking about a friend. I mean a family member that you love that's going to happen. And addiction treatment has not changed in 50 years. We keep doing the same thing. And we have been fed this story, this line from Hollywood and the press that people have to struggle and then hit bottom, wreck their lives, and then go off to treatment. And then everything's going to be great. And there's simply nothing further from the truth. There's no data around that, and it's not true. On top of the fact that only 10% of the people that are struggling with drugs and alcohol in America ever go get help. Help doesn't necessarily mean rehab. It just means AA. 10%. 90% of the people that struggle will never go get help. They're family members. Their family members are suffering as bad as the individual is that's suffering. And that's where we can facilitate change. I mentioned it took me 4 times through treatment ultimately. I spent 6 months institutionalized. And all of that impacted my family in a very significant and life-altering way. Other chronic relapsing diseases, things like diabetes, things like hypertension, we treat them totally different than we do addiction, right? If you go into the doctor and your glucose levels are 120 every time you go, your doctor is going to begin to talk about preventative measures from late-stage diabetes. We're going to discuss it. We're going to create a plan, and we're going to prevent. That's the goal. With addiction, we don't do that, okay? Now imagine this discussion. Let's say you go to your doctor and your blood work shows high glucose levels, and your doctor treats diabetes or pre-diabetes in the same way he's going to treat addiction, right? So what's that discussion look like? Oh, I see you've been eating a lot of donuts. That's very interesting. You know what you need to do? You need to keep eating those donuts. You need to keep eating the donuts so you have full-fledged diabetes. And then when we take your leg off, you will have learned your lesson. Maybe you'll stop eating donuts, right? Same thing with alcohol. We're not going to get ahead of it. We don't want to prevent it. We want you to wreck your life, wreck your family's life, blow everything up. Then we'll try to help you. That's addiction medicine America. You can tell I get irritated about it. I do, because there's so much help that we can do. There's so many changes we can make. And that's why we're doing U-Turn. U-Turn is a platform where family members can learn about addiction. It's the largest library of proprietary therapist-led addiction content anywhere in the world. We deliver this content over a confidential learning management system that we've designed. It works on any device, anytime. Our content is currently being utilized in some of the best-known medical schools in the country. Georgetown, Duke, Johns Hopkins, Clemson, USC. Their students are trained in conjunction with U-Turn content to learn about stigma of addiction. so that when they're in the ER helping somebody, they have less judgment and less stigma. Our services are being adopted by enterprises today. Businesses are buying our service to reduce risk inside of the workplace related to drugs and alcohol. And they're also doing this so they can supplement their company's employee assistance program and wellness programs. 18% of the workforce is going home to addiction. 1 in 5 employees is going home to a spouse or a child that's struggling with addiction. These employees are the same employees that use all of their PTO up by March. They're worried, they're not productive, they're missing work for appointments, and the health claims in that family are being driven up. If there is an employee whose 18-year-old daughter is struggling with opioids, that 18-year-old daughter is going to be on the company's health care expense for the next 8 years. Inpatient rehab, medications, therapies, whatever it may be. Okay? On top of the fact that the family doesn't know how to deal with this. U-Turn facilitates the very beginning stages of learning and change. And we drive people towards learning what options and support mechanisms may be in place for them. This is super important. We're not trying to fix addiction. We're not trying to stop people from drinking. That's not what our program is about. What we're doing is helping educate families to learn how to support their loved ones. And in doing so, that helps facilitate change for the loved one. We begin to make a difference in addiction medicine by engaging the family holistically at the very beginning, and then help guide people towards whatever resources might be best. There are a number of resources that are available for anybody, whether it's a local nonprofit or whether it's an addiction treatment facility. We don't care what they do as long as they get help. U-Turn is making a change today. We're running pilot programs with the Illinois Army Reserves, and we're beginning a program on October 1st for the South Carolina Veterans Administration with 250 very high-risk veterans. The federal government is indicating that they believe in what U-Turn is doing. So we are making a difference. We're very excited about our program. We think we can help change the way addiction is focused and treated today in America. And we really appreciate the opportunity to talk with Lifebulb and Orexo and possibly work with Orexo in facilitating change through the delivery of U-Turn services along with potential pharmaceuticals that might be delivered to family members. Thank you.
Thank you so much. This was the final presentation, and we're going to go back to the jury.
Okay, I mean, I said it yesterday, and I just want to reiterate it again today, that it's great to see that this U-Turn is unique in that it's a resource for family members, because as we know about addiction, that the person struggling is not the only person impacted. This is a family disease. So I'm excited to see that. I like the early intervention, through EAPs and things of that nature. Just moving forward, I don't know if you had covered this or not, but outside of EAPs, what are other ways that this could be reimbursed? Are you looking at it through payers? I mean, if you could just talk to me a little bit more about that, I'd be interested.
Yeah, no payers. So right now we sell the service through insurance brokers. Okay, so insurance brokers that do employee benefits plans or property casualty plans, risk mitigation for the business, they've already got the client. So they're selling U-Turn services as a supplement to the EAP and to the wellness program. By doing it that way, I don't have to sell to consumers. I don't have to sell to payers. There's no reimbursement. It's just a low annual fee for the enterprise. Ultimately, it reduces risk for the enterprise. That's why they're buying it, right? But it's that supplement for the employees is what we're trying to do.
Awesome. Thank you.
Sure.
Jay, it's Jeff. Are you licensing all the content, or how are you getting all the content and keeping it updated? What's your content management strategy?
Yeah, so all the content's proprietary. We make all the content ourselves. We built a set inside of a platinum recording artist studio. We did that about 1.5 years ago. And we're in the studio every month making additional content. We have over 300 videos today, but everyone is therapist led. It's all real people, experiential content. Because the idea is, if you think about how an AA meeting might run, if you're a family member and you've never done Al-Anon, just 1 hour of watching content can save like a year of pain trying to figure it out on your own. So it's just experiential more than anything else.
Shay, this is Aaron. I have a question about this is an innovative product. I mean, I said this yesterday. I echo others who've said the same thing. So I'm interested in the content. Is there content specifically for adult children and then for adolescents and younger children, or more specifically adolescents and adult children? Because we know that content's not going to be one and the same. It needs to be different. And so does your platform address that, or is it one we're providing it to the family and then they sort it out themselves?
No, we have 25 different individuals being interviewed through experiential learning. And what I like best about it is, I'll give you an example. We've got Joey Klotz. He's 34 years old, but he talks about his experience struggling with marijuana in high school, progressing as an IV heroin user. A parent can now watch that and understand what Joey's frame of mind was in middle school, high school, and college, right? So it allows any type of family member to view different content and then learn from their perspective that they're hearing. Does that make sense? We do have people that cover the gamut, basically every substance and all the different lifestyles. So there's something for everybody on there, but I mean, granted, we continue to make content all the time.
It makes sense. And we're seeing an increasing younger population that are experimenting. I think the youngest I've seen is 7 or 8 with alcohol, probably seen younger. So I'm glad that you have those different experiences for your users. Thank you.
Sure.
Okay. Thank you, Shay, and thank you to the jury. Let's bring back Michaela. Okay, well, I think we can agree that this was quite the experience, right? A very diverse group of presenters and fantastic delivery. I also want to thank the jury, of course, for thoughtful questions augmented by yesterday's session that unfortunately, not everyone has heard, but I really want to thank everyone for the passion, the content, the delivery today. And we're going to move into a very short break of about 25 minutes or so, 30 minutes, and until before we will sit with the jury and deliberate. But everyone else who's not part of the jury will have a break until 1:15 Eastern time, which is an hour and 10 minutes from now. And we will then gather back here again and announce the winner of the first Lifebulb Orexo Innovation Challenge. So, Michaela.
Super exciting. Nothing really to add to that. I think, Karin, you wrapped it up perfectly. Thank you so much for everyone's participation, not only the ones actually being in the call, but everyone listening in. Yeah. We really appreciate the interest, and again, everyone on the call. Thank you so much for your work and really even applying to this challenge. We really appreciate it, and seeing such a wide, diverse group of companies from really early stage to companies actually being in market and having a stable revenue stream. It's been a treat. So thank you, and we'll be back soon.
Back soon, and to the jury, we'll be back at 12:30. And until then, maybe grab some lunch or a snack.
Or dinner, here.
Or dinner, sorry, Michaela, sorry, Kaisa. Or dinner. Okay, see you soon. Thank you.
Hi, Michaela.
Hi, Swati.
Did you have dinner?
I didn't. No, I got caught up in work, unfortunately, but there will be time for that later.
My intern was from Sweden.
Oh, really? Where about?
Near Stockholm.
Okay.
Yeah.
That's pretty much where we're hanging.
Everybody is, right? Yeah. I guess her family, she grew up in the States near where we're headquartered and we're in the Seattle area. But then her family has a home over there, a summer home. So they were there for the summer up north, I guess. And now she's back in Scotland. So
Wonderful. Sorry, I think we're supposed to be muted. Karin, apologies.
I think we can be unmuted if we have. Oh, you mean the recording? We are back. Okay, so welcome back, everyone. And the jury has deliberated, so we will soon be announcing the winner to the first Life Bulb and Orexo Innovation Challenge. So first, I'd like to thank again Orexo and thank Michaela and the team over in Sweden and the US for embarking upon this journey with us. And Michaela, maybe we say a few words again before we go forward to thanking the esteemed jury.
Exactly. A few last words before we announce the winner and thank the jury again, of course. I mean, these 2 days, obviously, just a few of us were privy to yesterday, but again, these 2 days have been really inspirational. We've had the pleasure of meeting this highly diverse group of companies each approaching the realities of substance use disorder in their own unique ways. And that's really what this is all about, finding that multifaceted approach, and understanding that substance use disorder does not have a one solution fit all. It's super personalized, and it's a chronic condition. And I think that all these companies today have really shown that, and it's been really a pleasure to listen to all of you today. And again, yeah, thanks for everyone for tuning in, and a big thank you to LifeBob for setting this up and for organizing this. It's been really a pleasure to be a part of.
Thank you. Thank you so much. We've learned a lot today and yesterday and over the past few years, and especially past few months. So let's bring out the jury, our wonderful jury, and put them up on the screen. So thank you to all of you. Thank you to Aaron, to Phil, to Jerry Lynn, to Jeff, and to Kaisa. It was a difficult job today. And Jerry Lynn, as the chairperson, will soon be delivering the answer, or telling us who's the winner. But thank you. Next, we'll go to all our finalists, and we're gonna show you the finalists based on their the order of appearance. So, welcome to Mehran Talabinejad, Lucinda Koza, and Rohan Dixit, Bo Mann, and Richard Hambury first. Thank you so much, and congratulations. There we go, all of you who presented before the break. And next, in the break, by the way, thank you so much to Lisa Smith, our incredible motivational speaker. We really lived through what you went through, and it was very, very important to hear. So thank you now to the next round of finalists, being Swati, Tyler, Marissa, Shay. There we go. Go. Now we can see you from all your different locations, virtual or not, fictional or not, maybe rather. And Shay. Go. Okay, maybe Shay has taken a little break.
Sorry, I was on the wrong link. I apologize.
Okay, there you are. Thank you so much, and congratulations to all of you. So, and now let's bring back our chairperson, and also Aaron, our patient representative on the jury. So the two of you have been chosen by your fellow jury members to deliver the message. And so I'll ask Aaron to please start.
Well, first off, just want to say thank you to each and every one of you. This was not easy. People say that all the time, but it truly wasn't. So many great efforts being put forth. We really wanted to do an honorable mention to, a product that we know is needed, and given some time to develop and further grow, we think will be a great product, and that would be Lucinda and iAlly. We really wanted to say as a group that your product and your efforts are so needed, and from my heart and from our jury to you, please don't stop what you're doing. Don't let this deter you. keep it up, and we know that we're going to see great things from you and from the support you're giving to caregivers and to allies and families. So thank you so very much.
And Jerry Lynn.
So I just want to echo what Aaron said. This was definitely a difficult decision, and everyone did an excellent job. And I'm hoping that you continue to do an excellent job bringing good products to the market as far as, helping folks in need. So after much deliberation, we actually selected Leaf. So Rohan, I was completely impressed because this particular product is really addressing comorbidity, co-occurring conditions. So, as you mentioned, anxiety, stress, they are big triggers, for use, substance use disorder, alcohol, and I was just really overall, the jury was overall very impressed by it. So biofeedback is key, because what you're actually doing is you're teaching an individual to pay attention to their body, in turn becoming in tune with your body and listening to your body kind of helps your mind take a proactive approach to managing thoughts and behaviors that could potentially lead to a relapse. So I think we all think that you definitely have something here, and we just wanted to award you with this and thank you so much.
Thank you so much, guys. That is incredible. I can't believe it. It's such an honor being with all these companies and with all of you in the jury and with Lifebulb. This is such a personal thing for so many people, and it means a lot to be able to help where we can. And thank you so much, everyone.
Congratulations. And here is your check. Normally we give out a very big one, a big check that you have to ask the aircraft to carry on in some way, but at least you can see it here on the screen. So congratulations, Rohan. Well done. But again, as I started out in the beginning, everyone is a winner. You're all so different. I think Michaela said it a few times, what a diverse and what a range of solutions. It's very difficult to pick one when there are so many different topics and ways of addressing the space, which by the way is exactly the issue here. This is an early stage therapeutic area, one could say, where we don't have all the knowledge on how to address it yet. So therefore the science is evolving and the solutions are evolving, and therefore we need a very multifactorial approach. And it's individualized in many cases, but the more we can learn about the science, which is I think Orexo and other companies are driving toward, the more we can learn about what will fit. So thank you so much for bringing all these solutions to the forefront. And we know we're going to be working with many of you. Hopefully you will also. One point the jury made during the deliberation was many of you should be working together. It's really wonderful if you could collaborate. And we hope that this kind of event will bring you together more than bring you apart, of course. So bringing together and do use these contacts, and always, you can always come back to us to find new ways of connecting. So that's really what we're about. We're trying to connect, we're trying to further solutions, and we're trying to improve people's lives. So thank you.
Thank you so much again, everybody.
Okay. So Michaela, I think that concludes our summit.
It sure does. It's been a crazy ride, and we've been working on this for quite some time, and it's amazing that it's had such a fruitful outcome. And we have companies like Leaf, like everyone else, really. All 9 of you have been really extraordinary, and I sat in on the jury deliberation, and I can attest to what Aaron and Geraldine said about it being very difficult to choose was no lie. There were some hot debates, and I truly attest to that we truly saw potential in all of you, and really for you guys to work together. I think we go back to this again, the multiple approaches, and some of you could really create some synergies amongst you. So yeah, huge thanks again. I feel like I've said that word about 1 million times by now, but really, I mean, it's been a full day, and yesterday was a full day as well. So thank you just for giving us your valuable time and knowledge and commitment.
Thank you. Bye now.
Bye.